We start.
Yes, sir.
We are live in YouTube also.
Sir, shall I start sharing the slide? My screen?
Yes, Malti, I think we can start.
Yes, please. Yeah, you can start. I think see both the speakers are there. Panelists have also joined. You can start.
Is my screen visible?
Yes.
Yes.
A very good morning to one and all. This is Dr. Malati. On behalf of Tambaram Ophthalmic Society, I welcome you to the 21st Cross CPD program. The topic for today is update on cataract management. Let's start the meet with the physician's prayer by Dr. Anuraj.
The physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hand, clear vision to my
mind.
Clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I may rely on thee.
Thank you, madam. Now I request the President of Tambaram Ophthalmic Society, Dr. Karnamudi sir, to give the presidential address.
Thank you, madam. Can you audible me?
Yes, sir, you're audible.
Good morning to everyone.
Good morning,
It's my pleasure to take part on 21st CPD program of Tambaram Ophthalmic Society, the update on cataract management. First of all, I welcome evergreen, legendary leader, President of IM Tambaram branch, President-elect of Tambaram, Tamil Nadu Ophthalmic Association, Dr. Nirmal Reddy. And also welcome the ma'am behind our success, Dr. Sunita. I also welcome all MC members, task members, ophthalmologists, and PG students of various colleges. The topic is update on cataract management is necessary for a day-to-day practice. It is our bread and butter of every ophthalmologist. We must know about do's and don'ts and management when the problem comes. In order to help us, we have most experienced speakers to share their knowledge and skill. I welcome Dr. Haripriya Arvind, Professor Dr. Leonel Raj, Dr. Lalit Kumar, Dr. Jayandan, Dr. Kavita Lakshmi, Dr. Ramesh Durai Rajan, Dr. R. Nayanar, and Dr. Srinivas Rao. So far, TAS successfully conducted 20 CPD program with an excellent topic and more informative to the members and the PG students. All this possible only with the proper guidance of our leader, Dr. Nirmal Reddy. Coordinated and cooperative work by Dr. Rachela, Dr. Anu, Dr. Sheila, Dr. Shobha, Dr. Vimala, our secretary, Dr. Moses, our treasurer, and other MC members. I should appreciate their sincere work. With these few words, I once again welcome you all. All the best. Thank you very much.
Thank you, sir. I'd like to invite the founder president, Dr. Nirmal Frederick, sir, to address the meeting.
Thank you, Doctor. So good morning, everyone. It's indeed a great pleasure and privilege to be part of the 21st CPD program, the continuing professional development program by the Tambaram Ophthalmic Society. And I thank the President, Secretary, and Treasurer and the organizers of this meet. Once again, a practical, solution-oriented topic and update on cataract management that will be useful to the delegates and to all our members. And it's very nice to see the established and expert speakers in the panel. The invited speaker, Dr. Haripriya, has a vast experience in the subject matter, that is cataract, and the topic is really interesting. Her secrets in managing the buttery soft and rocky hard cataract, two extremes of cataract. I'm sure this talk will be appreciated and will be useful to all the participants. And the care after surgery is very important, and this is where most of us, most of the patient-related issues also crops up. I'm sure Dr. Lionel Raj will be highlighting the important aspect of not only therapeutic care, but also the other care aspect after cataract surgery, because surgery as such is only half the battle, and the remaining half, the 50%, rest with the patients and the other team members. The session two, again, the raging debate between the rings and hooks. For rings and hooks, it's been going on for some time. And I'm sure today's debate will seal the decision in favor of the best arsenal in our armamentarium. And I welcome Dr. Lalit Kumar and Jayantan, who will be talking to us about the rings or hooks. I also welcome the other panelists, Chairperson Dr. Ramesh Durerajan. Happy to have you, RD, and Dr. Armugan Nayanar, the strict disciplinarian of many of our groups, Dr. Srinivas Rao and Dr. Anita Lakshmi. So once again, I congratulate the organizers and I wish the program a useful one. Thank you so much.
Thank you, sir. Now I invite Dr. Shubha to give the secretary report.
Good morning, everyone. This is Dr. Shubha, Joint Secretary of TOS, delivering the secretary report on behalf of Dr. Vimla, the Secretary of TOS. The Tambaram Ophthalmic Society was formally inaugurated on 23rd August 2015, following the IMA Tambaram Ophthalmic Oration by the then President of TNOA, Dr. K. Premraj. And TOS was affiliated to Tamil Nadu Ophthalmic Association officially in 2018 after it was ratified in the GB meeting at Puduviu 2018 for Puducherry. Next. Since its inception, TOS has conducted 20 CPD programs and TOSCon, the annual conference of TOS, till now. Next. The last physical meeting of TOS was conducted in 2020 March, which was an uveitis update. And in the same year, two virtual CPD programs, one on retina diagnostics and the other one on ocular trauma, were conducted. The annual conference of TOSCon 2020 was conducted on a virtual platform with more than 100 attendees, and it was very well received. In the year 2021, the 19th TOS CPD was conducted, which was an update on glaucoma, and we have next slide. And we had renowned glaucoma. The previous slide, we had renowned glaucomatologist Dr. Devan Tuli, Dr. Sunita Dubey, and Dr. Satyan Parthasarthi as the main speakers. And there were case presentations from PGs and also a lively panel discussion with many glaucomatologists, Dr. Chitra, Dr. S. Venkatesh, and Dr. Vijayanand participating in the panel discussion, which was moderated very well by Dr. Anu Rajadan. Our last CPD program was an update on pediatric ophthalmology. The keynote address was delivered by the renowned pediatric ophthalmologist and strabismologist, Professor Dr. Pradeep Sharma. And an exhaustive talk was given on the tips and tricks in the management of binocular vision by Dr. Manjula Jayakumar from Agarwal High Hospital. Next, there was, next slide. Next. There was also a lively quiz conducted by Roshni Desai, and prizes were given away to the winners. Next. There was a panel discussion which was very interactive and gave insights into the common problems encountered in dealing with pediatric patients by pediatric ophthalmologists along with the speakers. The pediatric ophthalmologists from our city were Dr. Praveen Krishna and Dr. Ram Prakash. And the session was moderated by the vibrant doctor, Dr. Shruti Nishant. So with this, we move on to the scientific session of today. Thank you. Over to Dr. Mal.
Thank you, Dr. Shubha. Now I invite the first speaker for the first session, Dr. Haripriya Aravind. She did a post-graduation at Arvind Eye Hospital, Madurai, and started her career as a pediatric ophthalmologist. She completed basic research fellowship at Kellogg Eye Center, Michigan, USA. She was the head of cataract and IOL services at Arvind Eye Hospital, Madurai for over a decade, and currently in charge of cataract clinic at Arvind Eye Hospital, Chennai. She'll be sharing with us the secrets for managing buttery soft cataracts to rocky hard cataracts. Welcome, madam.
Thank you, Dr. Vimla and the entire team of TOS for having me here. Can I have this presentation closed so I can share my screen?
Yes. There are two options: new share, resume share.
You have to unshare your screen and come out.
You have to stop sharing your screen.
Okay.
Are my slides visible?
Yes.
Thank you. So I'll be talking on this aspect of, like mentioned by Nirmal Frederick sir, about managing the soft lenses as well as the extremely hard cataracts. So I'll start with the soft lenses. Those soft lenses are considered the easier ones to tackle. Many of us would also realize in our practice that they are quite difficult sometimes. We land up with more issues with the soft ones. So one way to identify about the density, as we know, would be the nucleus color. This gives us a good idea when seeing the patients on slit lamp using loss grading or just on seeing on slit lamp, we'll be able to identify the density of the cataract. The second thing is the patient's age. A younger patient, typically the lens is going to be soft. And the older the patient, even if you're having a good red reflex, one has to be careful because you may have more denser leathery fibers. The challenges would be the cheese wiring, which could be a real issue when cracking or when trying to prolapse one pore and emulsify the fragments. The other aspect is difficulty in rotation. So this is because of the strong addition of the epinucleus and the lens fibers. So one has to ensure a complete hydrodissection is done, and also where possible, a good hydrodelineation also has to be done. So bowl formation could also be an issue because sometimes we tend to use a little more vacuum, and in the process we eat up the central nucleus matter. So we only have the periphery, which is like a bowl, and this becomes difficult to eat up, especially if you're having a smaller capsulorhexis. The techniques one could employ would range from phaco aspiration to divide and conquer, stop and chop, or the chop technique, based on the cataract density and the surgeon's preference. So phaco aspiration basically could be employed when the cataract is very soft and the patient is young and only has this either a PPC or a PSCC kind of a cataract, which does not actually need a divide and conquer or a chop to tackle it. A little more firm cataract would need any of the below techniques. In terms of the technique of choice, I prefer to do a chop technique. I use a horizontal chop technique in these soft lenses. So these cataracts actually can be quite different. So we tend to club them to be soft, but they could be either just a subpixelar lens in a young patient where it's a very soft lens and we aspirate it in toto, or the cataract where we have more of the cortical fibers with nucleus sclerosis grade 2, which could be the more difficult ones to handle. And the third type would be the more firm cataract with little more nucleus sclerosis. Those are a little more easy to handle. Those you could do a vertical chop or stop and chop or divide and conquer to emulsify those nuclei. So I'll show you all these three kind of cataracts and what would be my technique in these patients. So this first one, like I mentioned, is a subcapsular cataract. So a good hydrodissection is very, very important in all soft lenses. Also a delineation, because then you know the endonucleus size well, and then you also do it at different levels. So you kind of make your endonucleus as small as possible, so you know which is the part you'll have to actually remove. So you just have to go in these cases with phaco tip down and eat up the endonucleus. So these are the fairly straightforward, soft subcapsular cataracts. Of course, the PPC is a different story. One has to be a lot more careful. But once you in these cases, otherwise it becomes easier because you have both a good hydro dissection and delineation. The other kind of cataract, like I said, this is the one with the cortical cataract, and these are again soft, but here it becomes more dicey because we don't want to leave a bowl here. So adequate size rexus is important, a good hydro dissection. I think you can always err on the side of doing a little excess than little less hydro in these soft lenses especially. So I do a horizontal chop here. So with a horizontal chop, I use a straight chopper with a blunt tip. And with a horizontal chop, I move the chopper from the periphery towards the tip and separate the fragment. So you're just supporting the nucleus from the center with the phaco tip. No energy is required. And the movement is from the periphery towards the tip. That's why it's called as horizontal. And so the chopper has to be placed under the rexus margin and then moved towards and then separated. So again, if you watch, you support it, move the chopper from periphery to the center, and then chop. The other aspect is you're using the tip here only for mechanical support. So you don't have to use either power. In case you use power, you'll eat it up, so you won't have the central support. Nor will you use any vacuum or flow rate. So you're just in foot position 1 when you're doing this chop on these soft lenses. So look at the setting here. So this, I'm not using any vacuum or flow or power. I'm using the phaco tip only for mechanical support, moving the chopper under the rexus margin. The reason I'm going from center to the periphery, instead of going to the periphery straight away, is because we don't want to place the chopper on the anterior capsule. You want to place the chopper from the center, scratch the anterior nuclear surface, and then go to the periphery, and then bring it to the center, and then separate. That way, your phaco, your cracking becomes complete. So once you have about 4 fragments or so, then you can go on to the emulsification phase. Again, you want to use low vacuum and flow rate in these soft lenses because you don't need high. It's also not safe to have high settings. So one has to be having just adequate vacuum and flow and torsional ultrasound. Here I'm using the Ozil. I'm using it 60 on the Ozil here. But based on whichever machine you're using, you use just the minimum energy required here. And then another important factor is to also have a very stable chamber because of this high chance of, when you're having a pull with these soft lenses, your chamber may become unstable. You can have some surge, so you don't want that to have. This next case is a mature cataract. Again, it's a very soft lens. With mature lenses as well, the first challenge would be the rexus. The other challenge would be to do the chop. If it is an intumescent lens, you don't want, because you don't have the epinucleus and the cortical support, the chance of rent is quite high. So again, the same technique, I'm using a long vertical chopper with a blunt tip. Now this chopper is, I get it from Indo-German. I think Appasamy would also make it for you. But it's just a straight metal bend about 1.5 millimeter with a blunt tip. So that's why the movement from the periphery to the center does not increase your chance of rent. So this is an absolutely safe chopper and technique. So this horizontal chop technique, which I'm using in this case as well, is very safe and very useful for these very soft ones where a vertical chop may be more difficult. So from the periphery coming to the center, just supporting with a tip in the center, and then you kind of break it into very small fragments. I mean, as big as you want. And then I like to actually chop first and then eat the pieces and use the second instrument well. So second instrument, because adhesions are stronger in these soft lenses, second instrument can be used to feed the pieces towards the phaco. So use that instead of using just your aspiration for the followability, you can also use a little bit of your second instrument as well to direct the pieces towards the tip. Now, this is a more firm cataract. As you can see here, you tend to have a little more core, a little more white color compared to the normal soft ones, which you see on slit lab or on the table. So here you can do a vertical chop or more like an oblique, a kind of a combination of horizontal and vertical. With the chopper here, it is a straight one, but again, a little sharp tip. So you can have a regular, like a 1 millimeter, 1.25 millimeter chopper. This is made by Appasamy. So the same thing, if you have a very hard lens, then you'll use a 1.75 or 2 millimeter chopper for the vertical chop. But in a firm cataract, you could use a smaller chopper, sharp tip, and then go from above below. That is why the vertical chop. And then here you will have to use energy to support it. So just a little energy is pressed in with a phaco tip. You don't need much, just to hold it gently while you're moving your chopper from above below to chop it and then separate the fragments. So the normal goal of surgery would be to have break your pieces as small, because this helps enormously in emulsifying the fragments without causing any chatter or any too much of disturbance in the anterior chamber. So like I said, this last technique which I showed works well with these firm cataracts, and they're probably the ones which most of us would like to have. On a good day, that's the cataract which all of us would like to have. This is a patient with the penetrating trauma with a PC tear. Just showing this case for completion. So example, if this were a PPC, one would have to be very careful. We would not do a hydro dissection here, because this PC opening will open up more completely and lens matter will dislocate into the vitreous. I'm using visco dissection here. So this is also a technique which can be used instead of hydro dissection. One can use visco dissection to kind of separate the epinucleus from the capsule, and then use your phaco probe, again your phaco tip, the bevel facing to the side, and then remove the lens matter, being aware that there is a rent at this area. So one is very careful trying to do your emulsification and placing the phaco tip away from this area of the PC tip. Before retracting the probe in these patients with a PPC or with a PC tear, it's good to seal the rent. I use Viscoat here or Orocoat Plus to seal the rent and then retract the probe, because a dispersal viscoelastic is useful to prevent any vitreous prolapse or any enlargement of the rent. Being a large rent, I placed diol in sulcus, therefore a 3-piece acrylic lens in sulcus. Remove the viscoelastic, use pilocarpine, check for any vitreous, and then close. So to summarize, soft lenses, one would have to focus on good hydrodissection, extremely very important. So always err on the side of doing a little excess hydro, decompress the nucleus each time, and delineation also wherever it is applicable. It may not be very useful in patients with cortical cataracts. The other aspect is to know what technique you want to employ based on the density of the nucleus and the patient's age. A very young patient, 30s, 40s, presenile cataracts, all you have to do is just use your Sinskey hook as second instrument, phaco tip, bevel down, and aspirate it. The firmer the cataract gets, your technique may either be a horizontal chop or a vertical chop. That's what I would do. And then you'll also have to choose lower parameters. Lower vacuum and power are adequate. And number 2, more importantly, are the safer options. We do not want to go on high parameters with these soft lenses. Moving on to hard cataracts, the challenges, as we are aware, would be the reduced red reflex. We also have a densely compacted endonucleus with very little epinucleus, which makes it more difficult to separate these fibers. The capsule here is very thin, which makes it easier for us to do a large rhexis in these older patients who have thin capsules, but also has a higher chance of a PC dent. And zonules tend to be weaker in these patients with hard nuclei as well. Another area of concern is the corneal health, because most of these patients also are elderly and they may have lesser endothelial cell count. The prerequisites would be to have a just right side port incision. We don't want it to be too large. Sometimes we may consider making it larger to do a bimanual irrigation aspiration, but you may consider doing it later because we don't want any chamber instability, loss of fluid. So have a right-sized side port. This is true for any phaco procedure. You may want to use some stain on the capsule for a better rhexis, larger one. A mobile nucleus, which is not very difficult in harder nuclei. So because your hydro, even if minimal, your nucleus tends to rotate quite well. Dispersive viscoelastic is very useful. So using chondroitin sulfate before starting your phaco is useful to coat the endothelium and reduce the chance of endothelial damage. Again, because these nuclei are thick and hard, you'll have to actually either trench deep or chop and hole and impale deep. So for that, I'd like to retract the sleeve a little further in these cases. So at least 2 millimeter of the phaco tip has to be exposed. So based on the machine, one may either consider using a burst mode or a pulse mode or the OZL. I use the Centurion system, so I use the OZL. But again, pulse or burst. Burst is good for the chopping part and pulse maybe for the emulsification part. So it's good to pause the ultrasound instead of using continuous when using traditional ultrasound, because when you're using continuous, the chance of chatter is more. So you may have more repulsion. The pieces tend to move away from the tip. When you pause it with either the burst mode or pulse mode, the pieces tend to come towards the tip, so which means clearer cornea and also less chatter. The nucleus management, some of the principles are you will want to divide it into small segments, more so in a hard cataract, because the larger it gets, it takes longer to emulsify, which is not good for the cornea. Avoid any tilting of the lens while cracking or chopping, because zonules can be weak here. So just be aware of it. So I would also like to first chop all the segments, because this gives support, lateral support, instead of emulsifying as we're chopping. So first chop it completely and then emulsify is what I would suggest for mature cataracts and hard lenses especially. So stabilize the nucleus on the phaco tip before chopping. So that impaling is very important. So you want to hold down lower part of the nucleus, impale well, use 90% or more of the vacuum you have set on the machine, and then chop. So make sure all the pieces are totally separated from each other before you try and emulsify them, because if they are still connected, it will be like one big connection, and trying to prolapse it out will be a bigger problem. So if it is not separated, go back, impale once more or trench deeper, separate it completely, and then go for the emulsification. That makes your procedure, because at that phase you're putting the energy more in the bag away from the cornea, so your cornea will be clearer. But if you do it after prolapsing it into the AC, trying to emulsify this complete or near complete nucleus will only cause more endothelial damage. We need to also have more attention to the capsular bag during the last piece removal, because there is no epinuclear support here. So reduce the parameters for the last piece to reduce the chance of the rent. In a hard lens, I like to make a large nucleus, so you have more working space. So one can also use the stain, which is very useful for us to identify the capsule and have a complete rhexis. And also these capsules are thinner, so doing a rhexis is not difficult. To do a large rhexis is not very difficult. Hydro is done. I'm doing a chop technique here. So like I said, this is a vertical chop. A little burrow is done in the very beginning. The reason is only with that burrow, I can go and hold the lower part or the lower third of the nucleus. So to do that, one, the sleeve is retracted, more of the tip is exposed. Second, impale deep. So trench a little, impale deep, hold, ensure you're getting about 80-90% of the vacuum you have preset, and then place the chopper from above below. And this chopper also has to be a longer chopper than your normal one. So sometimes we're concerned, longer chopper may penetrate the PC as well. But these nuclei are so thick, so that happens very rarely. So I think one can safely use these long choppers with a sharp tip in these hard cataracts, because instead of trying to do with a shorter one which does not chop, using a longer one is in fact safer and works well too. And separated completely. So when you're separating, you're actually, it's fine. You're not going to cause any big zonular damage. So hold deep, impale well, and move the tip and the chopper away from each other, so that you are, so you kind of separate it. That is important for us to break. So this breaking has to happen completely up to the center. Otherwise, we land up with one central core nuclei or nucleus in the center, which again one has to, it can also be something which you can do later, to remove the central core alone as one piece and then remove the rest later. But otherwise you'll have to separate it well, so then all the fragments are completely broken. So if you're not able to chop with one go, what you can do is, if you see that I try once and I always go back and hold again. So I try to get the vacuum again, so I can chop once more. So there's a little second movement as well. So this way I am sure that I'm holding and doing my chopping maybe in 2 times. So I use 2 movements almost always with these hard lenses, because that way I can go deeper with my chopper, and I hold the second time with the tip as well when I'm doing it, and then separate. And like I said, break it into very small fragments. So this is very useful to prevent any chatter and to have clearer cornea, because these are less malleable, these hard cataracts. So unless you make it very small, you'll be using more energy, plus you'll also cause endothelial damage. So hold, and then since you're bringing it out of the bag or you're in the iris plane, use a second instrument either from above below or from the periphery to the tip, and then separate it. And then once the pieces are small, then you can emulsify them. So in terms of the setting, you have to use a higher power, higher vacuum, higher flow rate for sure in these hard lenses. You can always lower these settings towards the last piece, but you will have to have high settings most of the initial chop phase, because that is when you need to have good power. So this is another case which is again a very hard nucleus. I'm using the Centurion machine here. In terms of settings for this machine with the active Senti, I'm presetting an IOP of 44. So this is with some of the machines, but if you're not doing it, you can, whatever your machine height is. So when I would normally use a machine height of 120 with the gravity flow rate. So 120, whatever height one is comfortable with, but try to match that with your maximum aspiration and flow rate, which you can have with your machine. Especially in the chopping phase. Emulsification, this may be more dangerous as you remove. With chopping, your nucleus is completely there. So it is safe for us to use high parameters. Use high power during your chopping phase also, because your phaco, in that time, your energy is on the nucleus, not close to the cornea. So even if you use little more energy in that phase, when you're chopping, it's fine. You can reduce your power or your vacuum or flow rate when you're emulsifying it in the anterior chamber. So in terms of technique, make a small trench, hold deep, that is very critical. So it's a lot to do, not with the chopper, but more with the tip. So 2 things: one, hold on the lower third of the nucleus. Second, impale deep. That's when you get a good hold. And use your foot pedal to have high. So my machine, it's set at 600 vacuum in this case. So go to at least 90% plus of your preset vacuum. So you should have that good control. That's when your hold on the fragment will stay, and then use your chopper to separate it. So you'll have to do this. So first I would make sure my first central chop is complete, and then go and do the sub chop. So each half is then broken up into 3 or 4 pieces. And if you're not able to chop, don't worry, go back. It means you still have some nucleus material below that. So hold deeper in the same place, impale once, but don't go to the next part and do the next chop. Rather, re-impale on the same part, go deeper and hold again, and then separate it. So you want to finish the chop in that place before you move on to the next. That way you will find your, when you want to emulsify it and get the fragments up, it becomes easier. So the chance of dialysis and rent is higher here, as we are aware. So like I said, a little larger rexes is good. Always use, I use Viscoat or Orocoat Plus in these patients to give endothelial damage, which is very useful. I only use it once before I start the procedure, but that is probably adequate because it tends to stay near the endothelium, but use it for sure. And then I use HPMC below that. And then when you're emulsifying as well, make it very small pieces. Now, I also like the chop technique because your tip normally stays in the center. You don't have to go, too much towards the periphery. So you don't move your tip too much. You just have to, bring your pieces towards the tip. You also want to have this higher vacuum flow rate, because then the pieces come towards your tip. That's also a useful thing to have. And the power here is set at 60, the Ausl power. I don't use longitudinal ultrasound. I only use torsional. I use the Ausl IP, so a little of it may be kicked in, but most of the cases it's just the torsional ultrasound which is being used. But whatever, if you're using, based on the machine, either you can use the pulse mode or the burst mode as well. That is, also very useful to help bring the pieces back towards the phaco tip. The last piece, always reduce your setting. You want to ensure there is no trampolining of the PC. So a very stable chamber is very useful to handle this last piece. this is again a mature lens, but intumescent and hypermature actually, not intumescent. So with the leaky fluid is visible here. These are actually one of the toughest cases to do. One, because the zonules are weak, but more because the nucleus is mobile. So a very hard cataract with a mobile nucleus is very difficult to actually hold on to and separate and emulsify. So a divide and conquer here may be quite a challenging approach. So again, a chop technique may be easier because you can lollipop these nuclei. So use high energy here. You can see the sleeve here. It's actually quite well retracted. That's very useful. So retract it well, hold well, use your vacuum completely with your foot pedal control. Separate the chopper from above below, separate very gently because the zonules are also weak and the bag is partly empty. There's no cortical material, epinuclear material here. So that has to be very, you have to try and separate these fibers as much as you can. And also break it up into smaller fragments. At least once you can do it bigger, but when you're emulsifying it, break it into much smaller pieces. And every time you impale, not just in the initial phase, but later as well, hold in the lower fragment. So this is a 2.2 millimeter incision. It is based on what lens you're using and what is your technique. But again, whatever the technology, the basic principle is this, very good chamber stability. So your machine parameters should be adequate for these hard lenses. So don't go with too low and thinking you want to be safer for the cornea, because too low and using it for too long will actually increase the energy you're using in the eye. So you may want to use adequate energy and at the same time being emulsifying it at the iris plane, not going too close to the cornea. So those principles are the ones you'll have to adhere to. So you can see how loose these fragments are. So it's you have to be patient with them, but go one piece at a time and emulsify it away from the endothelium. So the energy here, which is like the CDE is mentioned, it is not much thanks to the new technology we have and better techniques, and use a chop technique is something which also reduces the amount of energy you're using. But in spite of it, you may have some edema, even in spite of using this coat. So a mild edema, like patient may have 1 or 2 lines reduction the first day post-op, which you'll have to explain to the patient pre-op that your patient will have a delayed recovery. So in dealing with hard lenses, one has to remember to take a lot of care to have a complete large rhexis. Always use a good viscoelastic for endothelial protection. A vertical chop technique is what I prefer. Use the right chopper. Adequate energy is very useful. Chamber stability and excellent fluidics are very important to have a safe procedure. And if required, in any rent or anything, one has to be prepared for conversion in the event of a complication. Thank you.
Thank you for the interesting talk, ma'am. Thank you for sharing the secrets of managing difficult cataracts with us. Now I invite the next speaker, Dr. Lionel Raj, Regional Medical Director and Post Director for DNB, Member Secretary of Institution Review Board, National and International Trainer for phacoemulsification and refractive surgeries at Dr. Agarwal Sai Hospital, Tirunelveli. He is also the scientific advisory for Rational Vaccine USA. He has won several awards. To name a few: Human Rights Organization Award, Indira Gandhi Sadbhavana Award, Indian Red Cross Society Award, and so on. And he has also won several awards for Best Paper and Best Video at various conferences. We welcome, sir.
Thank you, ma'am. Am I audible and my screen visible?
Yes, sir.
Thank you, one and all. I thank Tambaram Ophthalmic Society for having given this gracious invitation. I humble myself before my teachers, Dr. Haripriya, Dr. Nirmal sir, and I thank Novartis because this is a sponsored event for me from Novartis. So with this, I'm Lionel, and I'll be talking on the therapeutic care after cataract surgery. And I'll be focusing on certain elements which the company wanted me to talk on. So as we know, cataract is the leading cause of blindness, and most commonly performed surgical procedure across the world is cataract surgery. And we have the best person and the best reference, Dr. Haripriya, uh, uh, whose phenomenal work in the field of cataract surgery. Uh, we know all these from. And more than 5.1 million patients undergo cataract surgery annually in India alone. So this is a graph which I took from 2017 um, clinical and epidemiology research. The cataract surgical rates in India, if you see here, it's almost closer to that of the UK, approaching 6,000 cases per million population. Maybe we might have had some downfall last year following COVID, but we are no way inferior to any of the developed nations. And post-operative complications in cataract surgery, to name them, early complications are discomfort, bruising of eyelids, subconjunctival hemorrhages, allergy, increased intraocular pressure, flat chamber, clouding of cornea, decentration or dislocation of the implanted lens, infections, and toxic anterior segment syndrome. Late complications involve cystoid macular edema, retinal detachment, and PCOS, of which the most important and the ones which I will be discussing today are the inflammation, infection, and cystoid macular edema. The infections and inflammation, they are the most common complications following cataract surgery. They lead to significant morbidity and distress, and also they can impair post-operative vision or even lead to legal blindness, less than 660 vision. In addition, cystoid macular edema is an important post-operative complication of cataract surgery, and it's been documented that 2% of uneventful phacoemulsification also develop cystoid macular edema. And angiographic CME, not the clinical CME, angiographic CME accounts to nearly 20% of uncomplicated cases. And with pre-existing diabetes, the incidence may range from 45 to 55% also. So CME is a primary cause of reduced vision following both cataract as well as VR surgeries. Risk factors associated with poor postoperative visual outcomes following cataract surgery are pre-existing diabetic retinopathy, uveitis, glaucoma, pre-existing glaucoma, and medications for glaucoma, including prostaglandins, pre-existing age-related macular degenerations, intraoperative complications, previous vitrectomy style, and of course, very increasing age. So identifying patients with risk factors is important in taking the necessary steps to minimize post-operative complications. So how do we manage post-operative complications? The primary thing is, as far as American Academy says, it is the prevention. Prevention is the most important step in management of post-operative complications, and prevention is directly equivalent to prophylaxis. So goal of prophylaxis, we tend to give pre-operative prophylaxis, like with the we screen for adnexal infections, we screen for patency of NLD, we also give pre-operative antibiotics. Similarly, during surgery, we believe, and there are documented evidence on povidone iodine in preventing infections, as well as there are evidences on either sides with use of intracameral antibiotics. And again, Dr. Haripriya has a huge case series, the largest cohort in the world, I should tell, with intracameral drugs also. And post-surgery prophylaxis, that includes primary prevention for endophthalmitis and inflammation. The prophylactic agents used to manage post-operative complications, antibiotics is the one, and an AFRS survey said 81% of surgeons used a fourth generation fluoroquinolone as prophylactic agent against infections. Similarly, use of corticosteroids, drugs like dexamethasone or prednisolone, as we know, they are co-applied with antibiotics in preventing in infection and inflammation post-surgeries. NSAIDs. NSAIDs are used in combination with corticosteroids most often. NSAIDs, as we know, they have beneficial role intraoperatively in prevention of miosis and postoperatively in prevention of cystoid macular edema by stabilizing blood-retinal barriers and blood aqueous barriers. So complications of prophylactic regimen because of too many drugs, like 1 or 2 antibiotics, then steroid, then use of cycloplegics, use of NSAIDs. So a complex regimen can lead to confusion among the patients. I had seen patients who had come with charts, 805 this drops, 810 this drops, 815 this drops. So it is a complex thing. So that is one thing which leads to confusion among the patients. And especially if the second day is also operated sequentially, if a sequential bilateral surgery is done, then the complexity is further increased with the separate dosing schedules. And also that there is a complexity because of tapering of the steroid drugs. And as we know, instructions to wait for more than 5 minutes before instilling each and every drops. So in patients with concomitant eye disease, patient may need to manage nearly 14 drops or more per day with 4 or more different bottles. So studies have also shown that more than 92.6% of patients instill eye drops improperly. Factors affecting postoperative regimen, prophylactic regimen. The prophylactic regimen is complicated by a number of factors like patient compliance, patient's inability to correctly instill the eye drops, lack of an understanding of the importance of the prophylactic treatment, proper method of administration, drop storage, and dislike of instilling too many drops multiple times a day. So all these justify the need for a combination of fixed dose of medications, or in other words, less drop prophylactic regimen among post-cataract surgery cases. So the important factors for selection of medications to manage postoperative complications, we need to consider potency and clinical efficacy of the drug, patient compliance, and the dosing regimen. The fixed dose combination formulation with reduced complexity of dosing can fulfill the above mentioned factors and aid in better management of postoperative complications following cataract surgery. Let me discuss one after other. The first thing which I would take is the role of moxifloxacin 0.5%. Moxifloxacin, as we know, is a fluoroquinolone 4th generation, which has a wider spectrum of activity against gram-positives, unlike the lower generation fluoroquinolones. And also they have a spectrum of activity against some anaerobic pathogens and gram-negative organisms. Primarily, Pneumococcus, Haemophilus influenzae, methicillin-susceptible Staph aureus, Enterobacteriae, and to some extent Pseudomonas aeruginosa. The best thing is it has better penetration into the ocular surface when head-on comparison with gatifloxacin is concerned, and it delivers a concentration thousands of times greater than MIC in the aqueous humor. And one another better thing about moxifloxacin is that the drug itself is a preservative. So most often we don't have to have preservatives to store moxifloxacin. So a need for more than just an antibiotic. As I said, recommended treatment measures require both antibiotics, steroids, NSAIDs several times to manage, and patient has to have independent timing of doses. So it all justifies that antibiotic can be combined in fixed dose combination with steroids.
அந்த வேலை பாக்ஸ்ல எறும்பு உரிச்சா அதனால சரி பொட்டனா முளைச்சா முளைக்குது முளைக்காட்டி ஐயோ சாரி நான் ஏதோ ஐயோ
apologies for it. So this is one of the paper which is original research which has been published. So a fixed dose combination has potential to offer efficacious and safe treatment, just comparable to separate administrations. I'll take you all with three different studies combining which worked combining moxifloxacin and dexamethasone. As we know, moxifloxacin, 4th generation quinolone, acts against DNA virus and topoisomerase 4. It's a bactericidal drug, and it's widely being employed as primary prevention against ophthalmic infections. Dexamethasone, as we know, it's a potent corticosteroid that can inhibit most of the inhibitory the inflammatory cytokines, and they can work both against cyclooxygenase and both the pathways of arachidonic acid metabolism. So some of the clinical evidences. The first study, I'll take a fixed dose combination of moxifloxacin dexamethasone after cataract surgery. The second study is again a fixed dose combination in post LASIK surgery, and the third one in Asian population. So this has been published in Current Medical Research and Opinions. Here, when we compare individual dosing and fixed dosing, day 1 and day 15, almost all patients were free from ocular pain with both types of dosing. So I would tell a fixed dose combination is non-inferior or equally efficacious as individual dosing capabilities. Similarly, reduction of ocular signs of inflammation by day 1 and after 2 weeks. All patients were free from ocular signs and signs of inflammation in the eyelids and conjunctiva, with both fixed dose combination and conventional therapy. All patients had reduced inflammation intraocularly with fixed dose combination when compared with conventional therapy. And there were no changes with the IOP from the baseline when compared with fixed dose and conventional therapy. So it all states that a fixed dose combination of moxifloxacin dexamethasone is equivalent and non-inferior to individual dosing of moxifloxacin and dexamethasone. Similarly, this particular paper discusses on the use of fixed dose combination post LASIK. Almost all patients were free of ocular pain with both fixed dose combination and conventional therapy from day 1 till day 15. Burning sensation relief was also similar in both the groups. Each relief, steroid being a potent anti-inflammatory, potent anti-allergic, each relief is also similar amongst both the groups. So this again establishes, this study establishes that use of fixed dose combination post LASIK is again equally efficacious as individual dosing. This is a particular study which is actually an open label single arm trial and in Asian population. So it's interesting to note nearly 97% of people had no pain at all after 2 weeks with the combination therapy among Asians, and 3% had very mild pain. So that states pain relief is very good with fixed dose combination even among Asian population. Similarly, inflammation of the conjunctiva, eyelid and the cornea, a fixed dose combination was very effective. IOP again, there's no abnormal rise or peak in IOP all through the period of 2 weeks. So moxifloxacin dexamethasone fixed dose combination is a patient compliant combination. Patient just has to use one single medicine for the benefit of 2 drugs. So it enhances better tolerability profile, ease of administration, does not sting, burn, cause redness of blurred vision, and above all, it's a self-preserved agent and no preservative related surface toxicities exist. So what these 3 studies added, they're more convenient, help in better treatment compliance for the patient, and increases likelihood of receiving proper dosing. So along with corticosteroids and antibiotics, NSAID also plays an important role in the management of cataract complications, and especially in diabetics, as I said. So Napasinac 0.1%. Previously, 10-15 years before, we were using flurbiprofen, and then came ketorolac. They all had established role in prevention of intraoperative myosis and post-op CME. Napasinac 0.1 is then that came into market, and as we all know, that has good efficacy on macular swelling. And this is a paper which compared Napasinac with dexamethasone versus only dexamethasone on macula. It's interesting to note, when there was a combination, the macular volume change was very less when compared to placebo plus dexamethasone group. And similarly, most patients were pain-free in the group where Napasinac as well as dexamethasone were used. So Napasinac is used in prophylaxis in cataract surgery. As we know, Napasinac is the prodrug which rapidly penetrates the cornea and gets converted into Amphenac, which is the active metabolite. Both of them act on cyclooxygenase pathway, and they inhibit prostaglandins and some of the leukotrienes, and they reduce inflammation, and more than that, they stabilize the blood aqueous and the blood retinal barriers that contributes to CME formation. Advantages: in contrast to other NSAIDs, Napasinac is a prodrug, and its active metabolite both act in stabilizing blood aqueous barriers. Bioconversion is there's a greatest bioconversion in vascular tissues of the eye, like iris, ciliary body, retina, and choroid, which are the regions which are most important for us. So Napasinac efficacy benefits, they have good, they are very effective in pain relief and inflammation associated with cataract surgery, and also they can reduce risk of CME. So now let me compare 0.1 with 0.3% Napasinac, fortified Napasinac of 0.3, which is the only the biggest advantage is once daily application. So this is a phase 3 study published in JCRS in 2014. Advantages of Napasinac 0.3 over 0.1: higher concentration of active molecule, reduced particle size compared to 0.1. That in turn increases the surface area for dissolution. And very important thing is added HB-GAR and even polyethylene glycol into the composition. That overcomes the disadvantages of surface toxicity following topical NSAID application. So a convenience of once daily dosing with equal efficacy and safety benefits, similar to that of 0.1% Napasinac used 3 or 4 times a day. So some of the clinical evidences I'll rush through. Relief of ocular inflammation with 0.3 is similar to that of 0.1 at day 7 and day 14, or in other words, it is non-inferior. Relief from ocular pain, similarly, they are equal. More than 90% of patients were free of ocular pain with both types of formulations. And prevention of CME, especially in post-diabetic patients, this phase 3 study which has been published in ophthalmology, a pooled analysis of 2 RCTs, which clearly says Napasinac 0.3 compared over a vehicle reduces significantly the risk of macular edema and also improve BCVA characters. So this is the pooled analysis of the 2 studies. The study 1, where comparison between vehicle and 0.3% Napasinac, it's interesting to see 0.3% Nepafinac is the incidence is 2.3%, whereas the vehicle is 17.3%. So significantly lowered in both the studies and also in the pooled analysis by 4 times. BCVA improvement in one of the studies, it was identical, 48.8 lines in 0.3 Nepafinac and 50 characters in the vehicle group, whereas the other studies showed clear benefit, and the pooled analysis again 1.18 times 0.3 Nepafinac improved the BCVA when compared to vehicle group. And this is more important for us when we consider the macular volume. The macular volume tends to be well maintained in Nepafinac 0.3 treated group when compared to the vehicle groups. Safety profile, 0.3 Nepafinac, 0.1, they are equally well tolerated. And as I said, the biggest threat with NSAID is the surface damage, especially when we use for 2 or 3 months in diabetics. So that is being taken care with addition of HPGAR and polyethylene glycol into the formulation. In addition to all these things, post-operative therapeutic care, based on the need, sometimes we use fortified antibiotics, we use cycloplegics, we use anti-glaucoma drugs, we use antioxidants sometimes to improve the retinal pigment epithelial pump mechanism. We use oral and parenteral drugs sometimes and intravitreal agents. So those things are required for post-operative therapy in post-cataract surgery. But that was not the scope of my presentation. So that can be used appropriately. So to conclude, post-operative complications following cataract surgery occurs despite advances in technology leading to poor outcomes. Prophylaxis management plays a major role in prevention of these complications. Antibiotics, steroids, and NSAIDs, they are the key in prophylactic regimens. And fixed dose combination of moxifloxacin with dexamethasone appears to be a convenient and effective option in control of infection and inflammation post-surgery. 0.3 Nepafinac once a day application continued till 2 months post-surgery helps in prevention and treatment of ocular inflammation and pain, and reduces risk of CME, and especially with diabetics. So when we use individually, it is more than 12 or 14 or more times we are applying medicines. But when we use a fixed dose combination, say 4 times a day of moxifloxacin with dexamethasone, so that is 4 times, and 0.3 Nepafinac is 1. So just 5 drops for a patient in a day. So that's a simplified dosing regimen with equal efficacy. So a combination of 0.5% moxifloxacin and 0.1 dexamethasone as a fixed dose combination, and single dosing regimen of 0.3 Nepafinac is a formidable pair which is effective in managing post-operative complications following cataract surgery. So that is what I wanted to conclude with. I thank Novartis again, and thank you all for your attention and listening. Thank you.
Thank you very much, sir. Thank you for highlighting the importance of timely application of the appropriate eye drops pre-operatively and post-operatively. With this, we come to the end of our session.
If a clarification can be allowed, is allowed?
Yes, sir.
Yes,
Sure, sir.
Yes, thank you. Ma'am, Haripriya ma'am. Is
The ma'am had to leave, so she had
okay.
another.
Yeah, that was a wonderful presentation by ma'am, and I also manage hard and soft cataracts in the similar way. But I just wanted to ask ma'am and the panel In very hard cataract, when the posterior nuclear plate is inseparable, we can still proceed. You know, we can try to separate, and the central portion alone we can debulk, and we get, by doing so we get some space, as well as we get to separate the rest of the nuclear plate very easily. So that is also an added technique which can be beneficial. The panel can discuss on.
Kavita ma'am, would you like to take that question to the panel, ma'am?
Yeah, I think I will at the end of the session, or you want me to take it now?
No, that's an added point. That's all.
Yes,
So
yeah.
the central zone we can debulk,
Yes.
and we get some more space, and effectively we could make a chop.
Yeah, Dr. Ramesh sir and Dr. Arumugan Nair will also add a few more to that. It's a well taken point, sir.
Sure. I really enjoyed Dr. Haripriya's talk because it was comprehensive and so useful, and some pointers I learned. One additional point, if you wish, is that in soft cataracts, we can make an extra incision and use the side port in that incision to remove the subincial cortex. Sometimes cortex gets stuck up somewhere and you're not able to remove it with our regular instruments. You can make an extra side port to remove the balance cortex. Otherwise, the talk was absolutely fantastic. Thank you.
Thank you, sir. Thank you. Thank you, madam. Now we'll move on to the second session. Shall I take up? Yes, ma'am. Sure. Yeah, fine. A very good morning to one and all here. It's almost 2 years since we actually had a real lively interaction at TOS. Everything has been happening virtually, but thanks to our team of TOS office bearers, Dr. Karnanidhi, Dr. Vimala, Dr. Moses, and their undeterred spirit, under the able guidance of Dr. Nirmal sir and Dr. Rachula, their teamwork and the teamwork of the management committee members, it's been happening even during the lockdown time. And to make up for our earnings this time, we have a very interesting debate. It's going to be a wordy duel between two young dynamic surgeons. Good
morning, madam.
Good morning. One from the land of plenty, Erode, Dr. Jayanthan of KSI Hospital, one of the fastest surgeon, a brilliant refractive and a high-profile cataract surgeon of our time, to speak on hooks, the only means to manage small pupil. And on the other side of the battlefield, we have a man of few words, but more action, and a highly skilled cataract and refractive surgeon who believes technology and skill should go hand in hand to achieve optimum results. Dr. Lalit of Amrit Hospital from Namma Uru Chennai, Namma Chennai, to impress us on rings are the one and only ones to manage small pupil.
Good morning, madam. Thank you for the wonderful introduction.
Good morning.
I'd like to thank Tambaram Ophthalmic Society and my dear friend, Dr. Srinivas G. Rao, for, he had to take some revenge on me. So Jayanthan and he decided to bury me today, in putting me in a debate, which I really cannot win. Because, rings and hooks are always a very, very debatable topic. And I sometimes feel like an idiot because I really don't know how to defend. I'm still using rings and I'm still feel like an idiot because, see, in today's world where appearance matters so much, she's my favorite actor, the Wonder Woman, and our Talaiva from Chennai, Rajnikant sir. There's a gross difference when they are with makeup and without makeup. And I'm not sure whether you are able to identify the other two gentlemen. One is Dr. Boris Malugan with and without makeup, and the other person is Dr. Bhattacharya. Yeah, so definitely in today's world where looks matter so much, I still feel like an idiot defending the use of rings. When you get a very nice shaped iris when you use hooks, right? You can see this iris here. It is nicely, you can call it A shape, V shape, whatever shape. These are the fancy shapes which are more, attractive nowadays, rather than having a round pupil. which you will get using a Malyugin ring. So round pupil has absolutely no significance. The shape round itself is, out of form. So I still feel like an idiot using a Malyugin ring. And this is a situation when I have to actually use a presbyopic IOL. Now, a presbyopic IOL actually, does not, in a patient who has had the first picture shows you that we have used iris hooks, and the pupil is all nice and distorted, and the pupillary function, the pupillary reaction is totally gone there. So, though we use diffractive multifocals and trifocals in today's world, I still believe in one concept that all multifocals are pupil dependent. If you have a very large pupil or if you have a very small pupil, you're still going to have issues. There are going to be more glare, halos, dysphotopsia, whatever you want to call it, more aberrations if you're going to have a dilated pupil. And if the pupil is too small, then multifocality is not going to work. So when we use iris hooks, we get this beautiful shape, and that the shape will make sure that the multifocal doesn't work. But when you use a Malyugin ring, the pupil is still reacting. Your multifocality still works, and there is no pupillary distortion, because when we use the iris hooks, there is gross sphincter damage, and this sphincter damage makes sure that the pupil doesn't react. Whenever we use the Malyugin or the BX ring, the pupil is nice and round, and the appearance of the pupil looks really good, and it still reacts. But still, I still feel like an idiot using a Malyugin or a BX ring, because definitely iris hooks works much better. That is what I feel here, and I still feel like an idiot for using a Malyugin ring, which would actually give you a nice and round pupil, a reacting pupil, and the multifocal lens would still work. But I still feel like an idiot using a Malyugin ring. But talking about inflammation. So inflammation is something which puts down the entire effort which you take in dealing with such a tough situation, the small pupil. I think small pupil is one of the toughest situation for any surgeon. Let it be a new surgeon, or a very experienced surgeon. Whenever we see a small pupil, we are a little disturbed. Definitely, we put in more effort, we concentrate more, we put in all our skills, and all our sixth, seventh sense, whatever you call it, comes into action. So small pupil is always a challenge for even the most experienced surgeon. And when you do a beautiful job, the next day when you see this kind of inflammation, you see some synechiae things which are formed between the iris and the lens, it is a little this thing. But still, iris hooks are the best way of managing a small pupil. This is what is known for years, and everybody believes that. And I personally feel like an idiot still using iris hooks in situations where after the surgery we are going to land up with so much of inflammation. And you can see the other picture where the eye is really quiet and the pupil is slightly dilated. Yes, definitely there is some minimal sphincter damage whenever we use the Malyugin ring also, but still the pupil is nice and round, and the lens is very well centered. And especially if you're going to use a multifocal lens, your lens is going to be very well centered. The patient is going to have less pain, inflammation, and he's going to see much more clearly the next day. But still, I feel like an idiot using a Malyugin or a BX ring. And I'm very sure my opponent and my dear friend Jensen is always going to put this as the first point, that money, the Malyugin ring and BX ring are a little more expensive than iris hooks. Definitely, Malyugin ring is expensive, but the quality which it gives during surgery and the outcome which is going to give during surgery is going to be outstanding. And the Bhattacharjee ring is reasonably priced. So if you feel that it is very expensive, then you can always use the Bhattacharjee ring. But one more point which I want to highlight here is, I'm just going to show you a small 2 side-by-side videos of 2 cases. Here, the first one, I've used the iris hooks. You can see that I have to make 4 side ports to put these iris hooks inside the eye. And these side ports have to be very, very controlled. If you're going to make very big side ports, then you're going to have a lot of surge, because fluid is going to leak from 4 or 5 incisions. How many ever incisions you're going to make, the fluid is going to leak through them. So we have to reduce all our parameters. We have to reduce our the vacuum which we use, the AFR which we use during surgery, and definitely it is going to take more time. There are a lot of studies which have shown that if you use iris hooks, an experienced surgeon is going to take 14 to 15 minutes more for the completion of the surgery than compared to when he's going to use a ring, whether it is a Bhattacharya ring or a Malyugin ring, doesn't matter. And for a surgeon who's not that experienced, he's going to take around 24 to 25 minutes more if he's going to use the iris hooks, whereas compared to the use of a Malyugin or a Bhattacharya ring. So definitely, I feel time is money. You can actually do one more surgery in that time, and you can actually make up whatever you're going to spend on the Malyugin or the Bhattacharya ring. So this is the way I look at it. But still, I feel like an idiot, and I don't know how to defend myself when it comes to a debate whether we should use iris hooks or Malyugin or a Bhattacharya ring. With that, I put my case to rest. Thank you so much.
That was an impressive missile from Dr. Lalit. Rings are pretty fast to use, and if mastered, can be easily inserted and removed, and it's ideal for multifocal IOLs, though it does have a little bit of splinter damage. And as you said, there's a study which shows that the surgical time for an experienced surgeon is around 4 minutes, and for a resident, it is 6 minutes in case of rings, whereas it is 15 and 18 minutes in case of hooks. Malyugin rings, again, are a bit expensive for an already expensive cataract surgery. So BHEX may be an alternative. Let's see how Dr. Jayanthan is going to give a counter for this. Dr. Jayanthan, please.
Thank you, ma'am. Lalit, can you stop sharing?
Yeah, sorry.
You're scared of my screen.
Yeah, I'm really scared of your screen. That's right. I'm out of it now.
I would like to thank Tambaram Ophthalmic Society for inviting me for this talk, and especially it was a very nice morning to actually debate with my very nice friend. Fine, I'll start sharing my screen. As you could hear from Dr. Lalit, he is all concerned only about the shape. We'll talk about the other parameters also. And to his surprise, I kept the cost as the last parameter and rest as a parameter. So I'll start my debate. Thank you. And so whenever it comes to a debate, or when you want to compare two equipment or an instrument or whatever it is, you need to have certain parameters on which you compare both the sides. So you can't just compare the plus of one and then minus of one, say that I am good and I'm not good. So we'll take these parameters and we'll try to compare both on these parameters. The first thing is the technicality. When I mean technicality, the ease of doing the procedure. Leave alone the time. See the procedure. See which is going to be easier. After making a main incision, form the chamber with viscoelastics. And once your chamber is formed, all you need to make is 4 equidistant paracentesis of just 1 mm. You don't need an extra equipment. You just use your same paracentesis knife, make 4 paracentesis. And you insert the hook. Make sure your hook is engaged on the pupillary margin and retract it, and you can leave it at the point where you want it to be and fix it with the collar. Repeat it for all the other 3 hooks. This is going to be the implantation technique, and take it from me, it is going to be very simple. You don't have any learning curve. It's going to be very easy than doing your phacoemulsification in a rock hard cataract. And coming to the removal part, once your phacoemulsification is completed with the formed chamber, all you need to do is just push the hook into the anterior chamber. It will disengage on its own, and then rotate it, bring it out of the paracentesis. Repeat this for the other 3 hooks. Sounds simple, and it works so simple. And with the viscoelastic, implanting and removal of hooks is going to be very easy, and any novice surgeon can actually do this without any difficulty. And as you could see, at the end of the procedure, the pupil is still perfectly round, maintaining its shape. Applicability, when I say applicability, the size of expansion. Okay. So as a surgeon, I always feel that I need to have a control of whatever I need to do. It's not the company or the manufacturer who need to guide. For a ring, it could be either a 6.5 or a 7 mm expansion. You cannot have something in between, less or more. But for a hook, you can have a dilatation of 5 mm or you can have a dilatation of 8 mm. According to your comfort, you can decide. So as you enter, keep all the 4 hooks. If you're comfortable being phaco in a 5 mm, so just leave it at 5 mm. Or if you want a really good visualization expanded to 7.5 mm. It's all what you wanted, and it is not what been dictated by the company, right? Coming to the shape of the pupil, when you use a 4 hook, you can have a square shape configuration, and you have a 5 hooks, you can have a diamond shape configuration. Given perimeter compared to a ring, the square and your diamond will give a larger area of exposure. When I say larger area of exposure, your visualization is going to be much better. So with the ring, whatever you're going to see will definitely be lesser than what you're going to have with the hooks. And the advantage of using 5 hooks over the 4 is that you can put the 5th hook exactly opposite to the place where you're entering with your phaco probe. So when you're doing a phaco emulsification, the iris will never come on its way. And the best part is you don't need any special equipment. Whatever is available in your OR, whatever is there is in your operating table set, you can just use it. You can use your lens holding forceps, you can use your non-toothed forceps. You don't need any special equipment. All that you need is a hook in your hand. That's it. But it's not the case for a ring. Whether it is a BH ring made in India or a Malikan ring made in Russia, whatever it is, you need a special equipment, and the cost is going to be there for that also. So versatility, when I say extreme meiosis, take for example a pupil with 1 mm, you cannot implant a ring in that case for sure. You have to go with your hooks only. Coming to the irregular pupil, for example, in such cases like a coloboma, you can't implant a ring because one half of the pupil is not there and the ring is going to be flapping around there. And definitely when you're doing phaco emulsification, it will get dislodged and it's going to affect your phaco emulsification. All you need to do is just put 3 hooks in the superior part, go ahead and do your phaco emulsification. It's going to be as simple as it is. Shallow chambers, yes, of course, definitely. You cannot put a ring which is going to make it more shallower and make your surgery more cumbersome. You need to put more viscoelastic, you're going to spend more, and you're going to damage the endothelium also. It's not the case with hooks. You're going to maintain the same chamber and you're going to do this. So it's going to be easy. And the advantage is that, another advantage is that you can use it for any procedure. May it be a small incision cataract surgery, phaco emulsification, a combined procedure with a retina procedure, you can use the hooks. And the most important advantage of all these things is that you can use it at any stage of your procedure, right from beginning. If you want to use a ring, you have to use it at the beginning. In case if you have a meiosis at the end of the procedure, when you want to implant an IOL, you cannot put your ring. You have to use your hooks again. So right from the beginning, after you're doing a rexus, when you have a complication in between, or if at the end of the procedure, you can implant the hook at any stage. Right. So we'll see an example. This is a case where an SACS, hooks has been used in case of an SACS. A small incision cataract surgery, mind you that if you're using a ring, after wheeling out the nucleus into the anterior chamber, if you're going to use your vectors, in case if you happen to catch the ring in between the rexus, in between your nucleus and the vectors, you're going to pull out the whole of your iris. The whole iridoralis is going to make it more messy. But it's not case of a ring, hooks. The hooks can dilate, stay there, finish your surgery, put your IOL, you're safer. And as you could see here, it's a neat round pupil. This is a complicated cataract where the iris is completely plastered. Would you again consider putting a ring in this case? I would not. I will prefer to do hooks here. And as you can see here, this is the second technique which I said. Put all your hooks inside the anterior chamber, and then after putting it, you can just sequentially dilate each and every hook. By this way, even a plastered iris, you can actually dilate it to the full extent. You don't need to do any mechanical stretching for these cases. So once the hook is engaged, stretched, and if the pupil is dilated, you can go ahead with your phaco emulsification. And once the procedure is complete with the hooks in position, you can hand over to your retinal surgeon who can take over from there. Right? If you have trainees in your hospital and if that trainee has ended up having a complication and you're called at a position where you can't see anything, where the visualization is not there, you can just go ahead, put your hooks and dilate the pupil. You can have a perfect visualization of the status of your anterior capsule, the ruptured posterior capsule, and now you can go aspirate the cortex and then implant the IOL under perfect visualization. And the same thing applies for an IOL implantation, like this case where the trainee has made a rent, you can't see the PC at all. If you're not sure whether your anterior capsule will hold your IOL or not, go implant a hook, dilate the pupil, see for the integrity of the anterior capsule, and a direct visualization, you can go and implant a hook. IOL. Okay, fine. Is it only for the pupils? The hooks is not just for the pupil, but the rings are only for the pupil. So in case if you have a gross zonular weakness, like in this case, you can do a rhexis, use the same iris hooks. There are different capsule hooks also, but you can use the same iris hooks to hold the capsule in position, put a CTR, do a phacoemulsification, such grossly dilated back also. This is not possible with your rings, right? So in case in a small pupil you are using a hook, and in such a situation, if you notice a dialysis, especially in cases of a pseudo exfoliation, all you need to do is just disengage your hooks from the iris, go back, put it on the capsule, retract, make sure the capsule is holding the hooks, and then it will be on position and you can go ahead with your phacoemulsification. Like in the second picture where you can see the hooks are used to hold the capsular back, phacoemulsification is done, you can implant an IOL. CTR insertion will also be much easier when you are using a iris hooks. Right. Forget about what Dr. Jayanthan or Dr. Lalit wants to say. All you need to do is go back to the literature and see what the literature says to us. This is the first ever report of a flexible iris retractor, which is reported in 1991. So we have crossed almost 3 decades of experience with the hooks, and it still holds strong compared to any of the rings that has come just 7 or 8 years back. This came as a letter to the Journal of HAO. Right. One argument which people would say that we are going to make 4 extra incisions, and that can actually affect the surgically induced astigmatism, especially when you're doing a toric or a multifocal IOL. And this is an article in IOVS which says that the study did not detect a statistically significant effect of the 4 incision for the iris hooks on the surgically induced astigmatism after cataract surgery with a temporal 2.6 mm incision. So you don't need to worry about the extra effect which is going to happen with the 4 paracentesis that you make. So you can go ahead and do your toric calculation as per the routine calculations. Right. This is a highlight. This journal in I, which is to be published, it is ahead of the print. So it's a very recent article, and this is the largest series of the reported series. It includes almost 1,140 cases which compared malignant ring with iris hooks. It says safety wise and the post-op, everything is going to be same for malignant ring and iris hooks. But remember, when it comes to the complication, there is a greater rate of iris tear with malignant ring. So the so-called shape of your iris doesn't hold good here. And this study says that definitely there is a lot of iris tears in a malignant ring compared to the iris hooks. Okay, fine. Let's see what the masters has to say. This is an article by David Chang, which says that in a managing IFAS with retractors, he says that iris retractors are probably the single most consistent approach that works equally well across wide range of IFAS severity and surgeon experience. It could be a novice surgeon operating on an IFAS or an experienced surgeon operating on a very severe IFAS. All that you need is just an iris retractor. And this is an original slide from Professor Boris Malugin. What he says is, if the pupil is too small, try to stretch it first. He doesn't say put his ring first. He says first stretch it. So all you need to do is stretch, then put his hooks, or put his rings. Better while you just go ahead with your hooks at the first sitting itself. Right. This is what Dr. Lalit wants to suggest. So affordability. So everyone knows for a cost of single disposable malignant ring, you can buy packs and packs of hooks for your lifetime. Nothing more you'd need to do. So coming to the technicality, versatility, applicability, scientific evidence, and the affordability, definitely you will also accept that hooks holds much better than the rings. Thank you.
Thank you, Dr. Jayanthan. That was a marvelous presentation and a terrific attack with a lot of supports from various studies. I do agree hooks are not only less expensive, but easy and simple to use, that it enjoys a wide application and acceptance and a huge fan following as well. It can be safely used even before and after capsular access at any stage, as you said. And these are definitely preferred in uveitic bound people. And as you had beautifully put it down, I now leave the audience to choose which is the best and which is good for them. And definitely surgery, I mean, exposure to the surgical field is a very important thing for any surgical good outcome. And it's just not a geometrical issue. Small people, we do have a algorithm. We should not just jump on to these mechanical devices. We'll have to first follow some pharmacological dilatation before resorting to all these. So now I request two important pearls for beginners who would like to use hooks. Dr. Jayantan, please.
Ma'am, I didn't get you.
Two important surgical pearls for beginners who would like to use the hooks, some surgical tips.
Okay. So the first thing is, when you're making a paracentesis, normally when we make a corneal entry, we generally make the entry slightly slanting upwards. But when you want to put a hook, always make sure your paracentesis is slightly pointing towards the iris, so that the hooks easily goes down and there is no damage of the Descemet's membrane at the point of entry. This is one point. Second, always make sure the chamber is filled, whether when you're implanting the hook or removing the hook. These are the two things. But the moment you go inside, you don't have any disturbance or difficulty in putting it. These are the two things which is very important. The position of your paracentesis and the chamber which is filled with viscoelastic. These two things are very important when you start your practice. But whatever it is, just forget the fear of putting your hooks. Even in a small 5 to 5.5 mm people, you can just start using your hook, slightly dilate, do your phacoemulsion, then you can go for a pupil which is very, very myotic.
Thank you. And Dr. Lalit, two important surgical pearls.
Definitely.
For beginners who would like to use Maligan ring or BH rings.
I want to know whether still Lalit favors rings or...
At the beginning of the talk itself, he said like an idiot, like an idiot. So he was compelled to do this talk rather.
It's a very debatable thing, but still definitely I personally feel both the devices have their role. Yeah. Definitely, if I am going to have a small pupil and if I'm going to, implant a multifocal lens, definitely it is going to be rings. Second thing, I think a 6 mm dilatation is good enough. Maybe a 5.5 to 6 mm dilatation is good enough to perform a cataract surgery, because our concentration is only on the rhexis and we concentrate on to remove the nucleus pieces through that rhexis, which is maximum going to be 5 mm, whether it's a monofocal, multifocal, whatever, doesn't matter. Okay, now talking about the tips, definitely hooks is it goes through a 2.2 mm incision very, very easily. So that's one more advantage. You don't have to make multiple incisions. Second thing is the Malyugin ring or the Bhattacharjee ring, definitely you will have to, that it comes preloaded. So once you go inside, you have to make sure those loops, you put it under those, under the iris. Engage them under the iris. And while removing it also, you just have to be a little careful. You have to make sure you disengage completely and then try to pull the ring out of the eye. Otherwise, sometimes you might cause a little bit of iridiolysis, sometimes, very, very rarely. So, with experience, you definitely will refine, and definitely the time taken is very, very less. The second thing is, I also want to tell them that you have to make sure you use something like chondroitin sulfate to coat the endothelium when you are going to use these rings, because initially there is going to be some manipulation and you have to be very, very gentle when you do these things, and better to coat the endothelium with the viscoat or any other chondroitin sulfate. That is one more very important tip which I want to give. And maybe you might have to also have a micro forceps sometimes to just put especially for the Bhattacharjee ring, to hold it and tuck it under the iris, those loops under the iris. So these are the only tips which I want to give.
Thank you, Dr. Lalit. As you said, BH rings can be implanted with microrhexis forceps. It doesn't need an injector. It's really a better alternative to Malyugin ring. And as you said, and as Dr. Jayantan had stressed, we'll have to use a good viscoelastic, and chondroitin sulfate is a preferred one. A little should be injected under the iris so that it can engage the iris well, both the rings as well as the hooks, for the ease of insertion. And for the benefit of the beginners, it would be a very good tip. And one more question for both of you. What would you do when patients are allergic to dilating drops and you do not dilate the drops? So what do? Do you go for rings, or you do try some other means before you resort to rings?
Jayantan?
If the patient is allergic to dilatation drops, Usually, even when we want to go for management of people, we need to go in a sequential way. Just inject the intracameral adrenaline first, and if there is no contraindication for adrenaline. Second, you can use a high molecular viscoelastics exactly at the edge of the pupil, so that will try to give a mechanical dilatation. And like Dr. Lalit, as Lalit said, like what you need is just a 4.5 mm of pupil. If you can make a rexus in that, you can go ahead and do a phacoemulsification. You don't need any expansion devices. So in case if adrenaline doesn't work, if there is no pharmacological means that works, no mechanical stretching that works, then you can go for a Hooke's method.
I personally feel that one is you can use intracameral adrenaline, because if the patient is purely allergic to drops, then either you can put, if you're talking about allergy, madam, am I right?
Yeah, allergy.
So you can use cyclopen instead to dilate the pupil. Maybe it won't dilate like your phenylephrine when you use phenylephrine or tropicamide, but still it will give you at least a 5 to 6 millimeter dilatation. So, it takes a little longer than the usual. So you call the patient maybe half an hour or 45 minutes before. If you don't want to do that, also you can use intracameral. That is the very wise thing. And third thing, sometimes, I do this, maybe it might be a little controversial. Anyway, we know that the patient is allergic to the drops. His eyes are going to become red. That's all, right? Nothing else is going to happen. And what is the treatment for allergy? You're going to use steroids. Correct?
Yes.
So put the dilating drops. Really doesn't matter. Maybe give a shot of Decadron IV or something. And after you remove the patch, the patient is going to put drops, which is going to take care of the allergy invariably. So why to break your head so much for for a small issue like this?
Yes. Yeah, that point is very well taken. And I've also heard Dr. Arup in his talk say that using 1 or 2 drops doesn't matter, because anyway, the treatment for allergy is going to be topical steroids, and it's going to be on topical steroids for another 4 or 5 weeks. So
one shot of Decadron IV will help in such patients, because see, our main concentration is to do a good surgery for him, and mild allergy should not bother you much.
So these mechanical devices are not to be resorted for just allergy in case
works,
of...
Yes, if nothing works, because why to cause more inflammation, why to distort the pupil for a simple reason like allergy?
Yes. And similarly, even 1% lignocaine, preservative-free lignocaine does a little bit of dilatation. So people who are
it's
on
available in the
topical...
market now. Entod phenocaine,
yes,
it works very well.
Yeah. So to sum it up, we need both these devices in our armamentarium, and the surgeon must equip himself and also be trained and adept at using both. And we should follow an algorithm and must not resort to these devices before we try pharmacological means. And at the same time, we should not hesitate to use these devices and expanders. So the earliest sign of any kind of intraoperative difficulty, like grade 4 or 5 cataract, or a very small and shallow anterior chamber, and if there is any associated pseudo-exfoliation, always a proper preparation will prevent poor performance. And this preparation starts from history taking. You should also take a good drug history, whether he is on tamsulosin or on long-term pilocarpine, or is on antiplatelets, because we need to stop these antiplatelets, because some minor sphincter tear will cause unnecessary iris bleed. So our army needs both Captain Hook and Lord of Rings. So I thank you once again, Dr. Jayantan and Dr. Lalit, for your esteemed presence and wonderful presentation, and of course for your fiery duel. Thank you.
Thank you, Tambaram Ophthalmic Society. Thank you, madam.
Thank you. That was an interesting, informative, and a lively debate. I thank Dr. Lalit Kumar sir, Dr. Jayantan sir, and Dr. Kavita Lakshmi madam for this wonderful discussion. With this, we move on to the third session for today, which is Cataract Conundrums, video presentation-based panel discussion on cataract surgery. I request Dr. Kavita Lakshmi madam to take over this and moderate the session. Would you like to introduce the speakers, madam? Yeah, I'll just ask you to introduce as well. Thank you for giving me this opportunity. And in this third session, the spotlight is on the video presentation of 3 very challenging situations we come across while performing cataract surgeries, and the tips and tricks to manage them.
This will be beautifully presented as a 1-minute video by each of the 3 expert surgeons, Dr. Ravi Kumar, Dr. Mehul Patel, and Dr. Seema, followed by a 5-minute discussion. And I'm sure there'll be a lot of learning experience for all of us. And I now request our chairperson, Dr. Ramesh Durarajan, a renowned ophthalmologist with great emphasis for values and ethics, and he needs no introduction to our crowd. He's ever enthusiastic to share his knowledge, and his quest for innovation through simple, easy, yet cost-effective ways of managing a tough case is a well-known fact. His video on toric marking will speak volumes about him and is a runaway hit on YouTube. It's indeed a pleasure and privilege to have you with us, sir. And I also invite our co-chairperson, Dr. Arumugan Nayanar, an eminent eye surgeon with excellent surgical skill and who strongly believes that one should learn from the mistakes and move ahead. He never hesitates to share his best or his worst for the benefit of other surgeons and in the larger interest of the patients. I now call upon also our one and only panelist for this session, the top and most sought after surgeon at Dr. Agarwal Eye Hospital, Dr. Srinivas G. Rao. Welcome, doctor. Now may I request Dr. Ravi Kumar from PRK Eye Center, Madhavaram, to present his first video.
Yes, I'm audible now?
Yes, you're audible, sir, but your screen?
Yeah, I'm sharing now. Okay. Can you know? Can you see?
Please proceed. Yeah, please proceed.
I'm just trying on my full screen. Yes. Are you able to see now?
Yeah.
Yes. Good morning, everyone. This is a wonderful session. Thanks for the opportunity. I'm Dr. Ravi Kumar, going to present about how to unpetal the rosette-shaped cataract. A 45-year-old female came to our clinic with a defective vision, the progressive loss of vision, with a history of blunt injury 2 years back, with a complete slit lamp examination and posterior segment examination with what is the needed important investigations like B scan and gonioscopy. We plan for the surgery. This video, we're going to highlight about what are the important steps we followed to manage or unpetal this cataract. Now I'm playing the video. This video demonstrates how to unpetal rosette-shaped cataract. During the posterior polar cataract, we plan to do a fireman-sized contraction after staining that class.
That was?
Yes, sir. That is my presentation, ma'am. Thank you. Thank you for the opportunity.
That was an excellent presentation, Dr. Ravi Kumar. And though
Thanks,
we may
ma'am.
not like to unpetal the roses,
Yes.
you did it to give a rosy world to this patient. I now request Dr. Ramesh sir to give his views on this.
Thanks, Dr. Ravi Kumar. That was absolutely a wonderful surgery. I know you're a master surgeon.
Thank
And
you,
all
sir.
your patients
Not
go
like
well.
you, sir.
Yeah. But I was actually, I'm not aware, is the posterior capsular dehiscence associated with these cataracts? Is there any literature pointing towards weakening of the posterior capsule in these kind of cataracts? Because I have done very few, 2 or 3. I have always treated it like a normal cataract and then hydrodissection. So is
Yes,
there
sir.
any presentation?
Yes, sir. Literature shows says that sometimes it is associated with the posterior polar cataract also and weakening of the posterior capsule, because this cataract happens due to the shocking wave due to injury along the fibers. So the weakening, wherever the shock waves went and damaged the lens fibers, the cataract formation is there. So we don't know that whether sometimes the posterior weakening may be there. Just have a precautions. So just follow what are the steps we used to do to the posterior polar cataract. I followed this one for the safer for the patient. Thank you.
Ravi Kumar, superb Ravi Kumar.
Thank you, sir. Thank you so
You
much.
had said that you had done a B scan for this patient. Was there any
Yes, sir.
bulge? Was there a defect in the posterior capsule? Was there
Nothing, sir. Everything, all investigation went on normal only, sir.
Was
So only
normal.
I confidently took.
Super Ravi Kumar.
Thank
I
you, sir.
request Dr. Arunga Nagana to give his comments, please. Dr. Arunga Nagana, can you unmute and please comment on this video?
Very feeble, sir. Can you come a little closer to the mic and speak, sir?
Hello.
Yes, sir. Audible, sir.
Yes, sir. It's a wonderful presentation by Ravi Kumar. Was there
Thank
any
you, sir.
zonal dialysis in this case?
No, sir. No zonal dialysis. All gonioscopy is findings are very normal only, sir.
Oh, okay, sir. Okay, sir. Thank you. Nothing more to comment. Already Dr. Ramesh Dorajan commented, and it's wonderful presentation. Thank you, sir.
Thank you so much. Thank you so much.
I have a small.
Yeah, fine.
Can I come in, madam?
Yeah, please.
Ravi Kumar, it's an excellent surgery. You're an excellent surgeon, I know. I just for understanding, I want to know what precautions you take while doing rexis, or in case of this cataracts, or in case if it extends, how will you handle it? And second
Yes.
point I want to know is what are the parameters you use in the phaco setting?
Yes, sir. Yes, sir. So for the rexis, we have planned for 5 mmCc sized rexis, because in anything happen to the posterior segment, so the lens fixation and sulcal fixation maybe is for having a safer side to have a 5 mm sized rexis. So the first point, we want to have a better visibility of the capsule, we stain the capsule. The second thing, wherever we lose the hold of the capsule, immediately we came out and fill up the viscoelastic and continued the rexis. With the minimal sharing and centripetal force, with the minimal tears, we continued that, we finish off the rexis. And if, that's your second question, yes, you asked if it is the runover somewhere happen. So what my approach may be that put a entry on the just opposite side of the runover, fill up the viscoelastic with the micro forceps, hold backward and centrally and recover the rexis. This is called by Brian Little, actually the technique is called Brian Little technique. My parameters is lower side only, because we want to have a normal pressure in the antechamber. So my bottle height is less than 70 mm, and flow rate is around 30, and vacuum is less than 300, and my power is 40. I fixed up 40, but minimum ultrasound are used, maximum aspiration only did, because the density is not so soft, but it like one NS2 and N2 like density. So I can easily manage with the soft chop technique. That's also. Thank you, sir.
Thank you, doctor. Thank you.
And Dr. Srinivas, just one question for you, sir. Like if a beautiful rexus, like how Dr. Ravi Kumar has made in this case, but usually it doesn't happen that way, because sometimes a long-standing trauma, there will be a very thick and calcified plaque, which is adherent to the capsular rexus. So the capsule may, the capsular rexus may tend to run away. Then it may cause a lot of stress on the zonules. So you have any special techniques to prevent the zonules from giving too much stress on the zonules?
Generally, I take all these cases in topical, and I avoid block because any positive pressure and all these things. In case if it is not very hard, then okay. And other things I want to suggest is always maintain the anterior chamber. Whenever necessary, repeatedly done the normal case where we enter and finish the case and come out. Repeatedly filling, as Ravi mentioned, maintaining the anterior chamber, what I will maintain so that they're not producing. And I will always try to do a supracapsular phaco in all this.
Thank you, Dr. Srinivas. Thank you. Now, next I request Dr. Mehul R. Patel from LV Prasad Eye Institute, Hyderabad, to present the video.
I'll stop sharing.
Yeah, good morning, everyone. Can you hear?
Dr. Mehul, we can hear you, but you are a bit soft. But we can hear you clearly. Thank you. While Dr. Mehul is starting his screen share, to comment on Dr. Kavita's query, I would prefer to use the intraocular scissors if there is a thick fibrosis of the capsule. So I will stain with trypan blue and remove the and finish the easy part of the capsule rexus. Wherever there is a scar, I will use the intraocular scissors to cut it. So the micro scissors can be inserted through the side ports.
And do you bring the nucleus up out of the capsular bag in such a case to do the phaco, or you do it in the bag?
From what I have seen, doctor, preoperatively, if I have a normal anterior and posterior capsule, then I don't anticipate PCR, and I would have personally done a normal cataract for this patient. This is just a soft cataract. I would have done a hydrodissection, and of course, be careful and do slow surgery, but I would have done a regular cataract for this patient, a regular surgery, not taken so many precautions. If I have an intact posterior capsule, anterior capsule on slit lamp examination, and I have a PCR, I will put it as bad technique. If the responsibility is mine and not the trauma. Trauma will usually cause an immediate posterior capsular tear. It won't cause a delayed tear a few weeks or months during our surgery.
Thank you, sir.
Dr. Mehul, can
Hello,
you
everyone.
share? Thank you.
Yeah, hello, everyone. I'm not able to share the video. So, do you have a video? Then can you share my video?
Yes, we have a backup, doctor. Moses, if you could just share. Yeah, just a moment.
So, meanwhile, just my video is on posterior polar cataract. So, basically, posterior polar cataract is always a challenging situation for the any NPS surgeons. So, I think there are so many techniques already published, modified technique, just like inside-out technique by Dr. Savla. So, there are mainly two important steps while performing the posterior polar cataract. First of all is a central 5 mm circular capsular axis, which acts as a landmark for the hydrodelineations. Second is a hydrodelineation step. So sometimes accidental hydrodissection can cause posterior capsular rupture and the high risk for the nucleus drop. So proper hydrodilation is very important. So
Your video is being shared, doctor. I think.
can you share now?
Yeah, it is already
So
being
in my
shared.
video, the importance of the visco dissection up to the margins of the posterior polar cataract. So it is the cortex removal in the end of the surgery, and also accidental hydrodelineations and intraoperative posterior capsular rupture. So after visco dissection, you can see that smooth visco dissection. Now you can see after doing that visco dissection. So this is the important step, particularly in the posterior polar cataract. So after doing that hydrodilation smoothly, you can do emulsifications, and you can see that posterior polar plaque, which is present after doing the nucleus management and the cortical sleeve. So after that, you can also implant the IOL and do the vitrectomy and remove that posterior plaque, or also you can do that young cap 3 months after the surgery. This is the important step what I would like to highlight to everyone. Thank you for everyone to give the opportunity. Now this is open for discussion.
That was a great way to manage post-polar cataract, Dr. Mahal, and with the intelligent maneuvering of the epinucleus and the OVD was used for visco dissection. Can I know which OVD was used for visco dissection?
Normal visco dispersive visco device.
Dispersive, like a visco chondritin sulfate. Okay.
Yeah, because it is because it's cohesive, you can't do this complete up to the margin of the posterior polar cataract. So it's dispersive.
And it also does offer a good tamponade. And Dr.
Yeah,
Haripriya had also emphasized its use for better visual outcome. Now I request Dr. Armugam sir for your comments, please.
Am I audible? Am I audible now?
Yes, sir.
Yes,
Yes, sir.
It's very clear. Thanks.
Okay, sir. And apart from what Dr. Mahar has told, and the important modification I make while operating on posterior polar cataract, all my tunnels will be longer than the usual to prevent the BSS coming out, so that chamber will not become shallow. Another important thing is I always keep it on continuous irrigation mode, but not in other cases. But in posterior polar cataract, it should be always on continuous irrigation mode. And your left hand side port should be slightly larger than the usual, so that we can inject a viscoelastic then and there to prevent shallowing of the anterior chamber. That 2 points that I wanted.
Thank you, sir. I do agree. One need to be really ambidextrous, or you have to train your assistant to do that. And Dr. Ramesh, sir, would you like to stress more on any of the? So kindly unmute, sir.
Thank you. So I think of posterior polar cataracts as 3 different types of posterior polar cataracts. One is the smaller one, like what we saw below 3 millimeters. They rarely cause problems during surgery. You can have a routine surgery. Then the posterior polar cataract can be, we mistake posterior capsular and posterior subcapsular as posterior polar. They are safe as long as you have an intact posterior capsule. And if you have access to a cirrus, you can actually see these posterior capsule extending right across smoothly. In 80-90% of PPC, you will have a posterior capsule that is smooth and extends. If you have an IOL Master 700 also, you will see it extend. And this we can't see with the slit lamp. So we are always worried about PPC, and we clump all PPCs together. All of us should get PCR and PPC only in about 5 out of 100 or maybe 10 out of 100, like 1 in 10 or less only. we should get a PCR. Because in all the 90 odd percent, the posterior capsule is intact, it may be weakened, and it should not give way if you do capsule surgery. So no need to give a bad prognosis and discuss too much with the patient pre-op, unless we have a very large, like more than 3 millimeter PPC, and you have evidence that it is bulging into the patellar fossa. Second, what Dr. Mahal Patel said is a correct thing to do, but my understanding is, if I have a weak posterior capsule, I want to have the least amount of fluid injected into the capsular bag. And if I inject anything into the capsular bag, I want the pressure to come towards the cornea, not press on the posterior capsule. So to have these two, I never do two-stage hydrodissection and delineation. I will not like to do too much of fluid injection. I would very much like to do what we said. Do a few small injects so that they come up to the posterior polar, but don't cross the midline. I will prefer to do that. I will keep the anterior chamber pressure low and do a very large rexis so that if it fills up, it will bulge forward. It won't bulge posteriorly. So I prefer to do a very large rexis, and the last thing is, he showed that he has removed the cataract, but there is a small white spot on the posterior pole. It's a temptation for us to go and disturb it. Please don't do it. Please put the lens. Please do the IOL implant. Please remove the visco everywhere. And if you feel very bold, you can just inject saline and wash it off. But if you touch it, if you touch the small thing, sometimes it will open up. Many times it won't. Sometimes it will open up. That is a weak spot. So don't meddle with that small posterior pole. You can yag it like what he said. So I like a large rexis, only do partial hydro. I don't do delineation. I like everything to come towards the cornea and not apply pressure posteriorly. That's all. Thank you.
Thank you, sir. Dr. Srinivas, would you like to add anything more to this?
Yes, thank you, madam.
Yeah.
Ma'am, my excellent surgery is shown. One thing I want to say, as Ramesh has said, it's a large rexis. I personally take concern. I explain to the patient as well as to the attender that in case rent is required, further anterior vitrectomy or other things required, I explain to them and take a special concern. Normally, I leave the concern part to my counselors. The situations I take personally to them and I explain with the attenders. Second part is I always concentrate on the rexis, for 5.5 rexis I may, so that in case necessary to place a lens in the sulcus. Third point is I never do posterior polishing, capsule polishing. In case if it is there also, as sir said, later on I do YAG. I don't know, it's controversial, but in case it is obstructing the vision, later on I do YAG.
Thank you. Thank you, Dr. Srinivas.
Thank
So to sum it up, no hydrodissection or very gentle hydrodissection and inside out hydrodelineation and a slow motion phaco is definitely needed, and a viscodissection of the epinucleus is a very good valid point. And if Dr. Lalit is there, does flax in any way help in posterior polar cataract management? Does it have any great advantage, Dr. Lalit? Okay, then we'll move on to the next presentation. I request Dr. Seema to present her video. She is from Arvind Eye Hospital, Chennai.
Hello, everybody. Good noon to everybody. Am I audible?
Very much. Kindly share your screen.
Thank you. Thank you to the organizing committee of Tambaram Ophthalmic Society for giving me the opportunity to present today. Mine is a short 1-minute video intended mainly for those people who are transitioning from the beginning stage of cataract surgery to handling more complicated cases of surgery that demands placement of a capsule tension ring. I would try to share my screen now. Just a minute. I'm trying to share my screen. Is my screen visible? Okay, I think.
It is blank, doctor. We can't see your screen.
Okay, sir. Just a minute. If it's difficult, I'd probably request the organizers to share from their end. I'm having some difficulty signing.
Dr. Bimal.
Is it available?
Yes, Seema, just a minute.
Sure, sure.
The video
Can't
visible,
hear
ma'am?
you. I can't hear the audio. You could start.
Tricks for CTR implantation. We always wish CTR placement to be as simple as in this case, but most of us know that the CTR, especially its trailing part, seems to have a mind of its own. Problem number 1. The last part slips into the anterior chamber and slips and keeps on slipping. My favorite left-hand instrument in this situation is the Coughlin's hook that prevents this slip. Problem number 2. The dehisced bag has a dynamic margin and it's not easy to manipulate the CTR under a rhexis margin that keeps moving proximally. And oops, the dialer is stuck in the CTR and the Coughlin's hook comes to its rescue. The best tool in this situation is to use a standalone hook like the iris hook or capsule hook on the rhexis margin and convert a dynamic bag into a stable bag. The CTR will then dance to your tune.
So like I said, it's exactly a 1-minute presentation, which is trying to show the utility of capsule hooks or iris hooks on the rhexis margin. It shows the different ways in which your iris hooks can be used, as was discussed earlier by Dr. Jayanthan during the debate. And it can easily convert a very dynamic kind of weak bag into a stable bag, wherein you can place the CTR as well as the IOL without much issues. My favorite instrument in cases of complications, whenever there is a PCR or zonular dialysis, and especially when the pupil is going down, is number one is the Coughlin's hook, because you can it's like a retractor. You can retract wherever you want, and you can do surgery under visualization. That is where both the Coughlin's hook and the iris cases.
Thank you. That was a very nice presentation, Dr. Seema. It was very well managed. And most of us do find it difficult to manage the trailing end of CTR unless we do have a second instrument. But the one point which is always a debated topic is at what stage the CTR has to be introduced. So I invite Dr. Ramesh on this to give his valid points and comments, sir.
Doctor, I don't use much CTRs, doctor. I've done less than 10 in my lifetime. So I'm not the correct person to comment on this except on theory. I will request Armughan Nayanar and Srinivasan D. Rao to please share their comments.
I too have very little experience. That too during my SCCS days, I tried once or twice. Then for the difficulty I faced, I gave it up. No longer.
Dr. Srinivas, sir?
Madam, even I too have very less experience on CTR, madam.
Okay.
I cannot expert comment.
Okay.
Really sorry.
So I would...
Doctor, in that case, we'll talk a little bit of theory, doctor, what we learned from others.
Okay.
So CTRs, I have seen 1 or 2 patients with intractable glaucoma becoming blind. They came to me with no PL, and I found the CTR in the angle. They had a nice CTR in the angle, and the patient had glaucoma and they become blind. So it's very important we don't lose the CTR in the anterior chamber. And the easiest way out of this problem is to put a 10-0 suture into one of the eyelets. So you can always guide the CTR by catching with the second instrument. You can catch either the thread and pull it out, or you can place it inside the eye. The second thing is, all of us have complications. The trick is to have less than the acceptable published level of complications. So for complex situations, please have micro instruments. I find having a micro forceps and a micro scissors, and there are many made in Tamil Nadu for a few thousand rupees. You will use it only once or twice a year, but on those occasions it will be of great use. So please always have one micro forceps and a micro scissors, and they should be in working condition. So using a micro forceps on the side port and catching the eyelet and introducing it, I've done a few and I have not had any problems, but I've seen a lot of complications. So you can thread the eyelet and you can handle it, or you can use micro instruments. Those are the only two comments I wish to make.
Sir, respected panelists, can I add, if you allow me?
Yeah, please.
Lionel,
please.
yeah. Regarding two of your questions, the second one I'll take now. Regarding when to introduce a CTR. Generally, my practice and most of the surgeons in the world also, they try to make the last. So, meantime, as Dr. Seema said, it's a good idea to support the capsular bag to the scleral vault using a capsular hook. So that is a better thing. And at the final stage, in order to transmit this particular stability without the hook, will be transferring to CTR. So this is what is the science behind. So generally, I make it before IOL implantation when everything comes out. Some surgeon even use CTR even before phacoemulsification, but that sometimes had disasters to trouble. And regarding your femto approach in PPC, there is one technique which has not been discussed with PPC, which has been published by Lee and Associates from UK, is the inverted Y or lambda technique. So in an immobile nucleus like in PPC, create a Y-shaped incision, means a Y-shaped phaco crater, remove a small pie from the Y, then you get space. You can use viscoelastics, or you can using that space you can do manipulate mechanically also for the nucleus. So similarly, femto may have an edge. Other than that, I don't think femto has an edge. Only that and rexus, I don't think femto has any additional advantages in PPC. Thank you.
Thank you for the valuable points. And I would like to just add a few points from my experience. So I do implant CTR, but at the early stage, like at the slightest sign of any kind of difficulty. For example, in case of grade 4 or 5 cataract and has an associated pseudo exfoliation. So after the capsular rexus and after gentle hydro dissection, I do introduce CTR. It does give a very good stable chamber and a very good support, because it's a very hard cataract, and at the time of phacoemulsification also can do a lot of with great confidence.
Yeah, many surgeons do that, but I prefer to support at the scleral vault using hooks, capsular hooks, and I introduce CTR at a later stage.
So I have a question to both of you. Do you size the CTR depending on white to white or the myopia or the lens cover? Do you size them?
Yes, sir. CTR comes from 10, 11, 12, that way. You're right. Ideally, a CTR should be sized based on the transverse diameter of the eye, either the white to white or the angle to angle distance. But generally, 11 millimeters suits most of the cases, and only in larger size globes, like the axial length is too large, we may require more than 11, 12. Generally 10 or 11. 11 is ideal, and 10 in smaller size globes.
So you normally have all the sizes, and you
yes,
white to white.
Yes.
Okay, my second question is, I have bought many and opened up and seen them. They seem to have different consistency and thickness. So can you just share one or two models which you prefer using, which you find to be good?
The Orlabs is very good. That is what I'm using for the last probably 16, 17 years. And even Alcons is good. Orlabs is very nice. It's very...
Orlab is cost effective as well.
Yeah, cost effective. Apasamis also I had used. Apasamis, sometimes they are very rigid, as you said, but Orlab is very nice.
Dr. Kavita, do you also size the CTR depending on the white to white?
Yeah, generally I use the 11 millimeter size, but in case of large bags, I do prefer a higher one. So, but generally I do use only the 11 millimeter size.
You are using them to stabilize the bag during phacoemulsification. That's why you
Yes,
prefer to use them
yes,
early.
yes, yes. And there's also a study that like in toric intraocular lens implantation, if you do a CTR, it also gives a better stability and rotational stability. So I haven't done that, but I just went through on literature.
Did you mean to say even without a zonular weakness?
Without a zonular weakness.
Oh,
Doctor,
I never did it.
To come back to that, doctor, that is not the regular CTR that we have in India. That's the Henderson ring. In the Henderson ring, the CTR's peripheral margin is not smooth, but it has got small 1 millimeter waves. So it has got ripples. And this was popularized by Dr. Warren Hill. And what he says is the ripples hold the loops together. But regular CTR has also been used with some of the
Kindly unmute, sir.
Sorry. So we all know that Technis toric is going to rotate much more than the Alcon toric. So if you have a patient where you don't want it to rotate and the patient is a myope with a larger bag, then what you can do is you can drop in the CTR but leave the proximal loop outside, implant the lens and leave the proximal loop outside. Then you can tie up the haptic of the IOL and the CTR near the eyelet. You can tie them together and then dial them both inside and then position them. So once you tie it up with a 10-0 nylon and you place it in the correct axis, it doesn't rotate. So you can anchor it with a suture if you're having the CTRs we have in India. If you have a Henderson ring, you can just put it in and expect the ripples to hold the toric lens in position.
That's so interesting, sir. Usage of endocapsular ring for the purpose of stability of toric IOL. That's interesting. That's interesting. But if there is a zonular dialysis, then toric implants are relatively contraindicated.
Doctor, we are talking about torics and CTR, not zonular dialysis and CTR.
That's interesting. That's interesting.
Patients with zonular dialysis, I personally would prefer to expect the haptics to stabilize the bag after IOL. So I don't see that as a strong indication. When I need to stabilize it, I would prefer to do something like a Sioni ring and suture it. I think we have to suture fix it to the scleral wall if we have an unstable bag. Just putting it in is okay. If it's a post-traumatic zonular loss and we don't expect it to progress, then it is okay. You can put in an IOL and leave it alone. But if it's a progressive condition like a pseudo-exfoliation, 10-20 years later, the bag IOL complex will dislocate with the CTR and we have to attach it to the scleral wall or to the iris or some kind of fixation has to be done. So CTR in a pseudo exfoliation does not make sense to me.
That means the global phacodonosis CTR doesn't work much.
And also it'll get worse. 10 years later, it's going to drop into the vision.
Yeah. That's because of the contracting forces of the capsule, and there are less unopposed forces on the zonules. So it tends to either migrate or even dislocate anteriorly or posteriorly.
Thank you, everybody. And if there are any questions from the audience, we'll be happy to answer them.
Madam, with the permission of the panel, if I may humbly add a few points.
Yes. Yes, please.
Madam, thank you, ma'am. Ma'am, the one thing is that when we are placing the CTR, when the nucleus is still in situ, before the phacoemulsification and you identify, the one thing is that placement of the CTR is definitely a little more difficult because of the bulk of the nucleus in the bag. And the second thing is once the phaco is completed, removing the cortical fibers which are stuck between the CTR and the bag is a little bit of a problem. It requires more aspiration and vacuum. And in a weak bag, the bag tends to be more pulled towards when you try to do the irrigation aspiration following the CTR which has been placed when the nucleus was in situ. That was one point. And the other point is usually we are advised to place the CTR only when the rhexis margin is completely intact. This is the norm, so that the CTR will stay in place. But I have found that in cases where the cataracts are hypermature, or with a calcified kind of an anterior chamber, and then we end up making not a rhexis but probably a capsulotomy opening with scissors, say intraocular scissors or vana scissors, depending upon the incision size. We make an opening which is kind of fibrotic. Then we don't actually anticipate the margin of those multiple nicks to extend. In this case, the nicks are not too many, maybe 4 or 5 nicks, and then you place the CTR in the bag if the capsulotomy opening is still quite small. So that can be done actually. And the third point is what Dr. Ramesh sir already said, is about the area of the progressiveness of the zonular weakness. If it's a non-progressive kind of a zonular weakness like traumatic cataracts, then well and good. If it's progressive weakness, I would also look at what area of the zonular margin is actually very weak. If I find that the superior area is actually very weak, then gravitationally over period of time, it's more likely that the margin will be, the bag will become weaker, and the CTR bag complex, IOL complex might drop in future. But if the superior seems quite stable, superior 180 degrees seems quite stable, and if the inferior infranasal or infratemporal margins, which are the weaker ones, then I would probably still go ahead and place the CTR. With or without capsule hooks, as deemed by the case. Thank you.
Thank you, Dr. Seema. And, are there any questions from the audience? So the audience seems to be really very clear with all the concepts. So, so thank you, Dr. Ramesh and Dr.
Ramesh, one question from audience.
Yes, please.
I am Dr. Ravi Kumar from Erode. A question to Dr. Ramesh. Can I ask, sir?
Yes, yes. You are most welcome, Dr. Ravi Kumar. Please ask.
Yeah.
All
the question sometimes
answer. Yes.
Sometimes it is with the slit lamp, find very difficult to differentiate posterior subcapsular cataract and posterior polar cataract. Do you have any clues? Because there are 3 types of posterior polar cataract. If less than very smaller size, you can go ahead with surgery. Sometimes if it is more than that, then the mid path. How to differentiate from posterior polar and subcapsular with the slit lamp? Can you give any clue, please?
Yes, Dr. Ravi Kumar, this is a very important question, and we all struggle. We have all struggled with this in our OP. So dilate it well and use a thin slit and carefully follow the posterior capsule. In most of the patients, you'll find a small gap between the posterior polar cataract and the posterior capsule. As we know, we all can make out the anti-hyaloid phase. It will be intact in these patients. So you will see the PPC, posterior polar, and then you will see a posterior capsule, which is actually extending beyond, and there's a small black gap of clear cortex. So those are the patients where it is probably safe. Dr. Daljit Singh has his eponymous Daljit Singh sign, where you're supposed to see white spots in the anterior vitreous. I have searched for it for 30 years, but I have not seen it till now. But Dr. Daljit Singh has actually seen a lot of small white flecks in the anterior vitreous in the presence of a break in the posterior capsule in PPC, but I have not seen them. But practically, I find that most of the publications say if you have something more than 3 or 3.5 millimeter, you have a higher risk of a posterior polar rupture during surgery. While the 1 or 2 or 2.5 millimeter PCC or posterior polars, that is what we normally see. So smaller ones, they all have an intact posterior capsule. Age also is a matter. If you see a posterior polar in a very young patient, most likely that posterior capsule is very thin there. It's not normal normal integrity will not be there. So younger patients and larger posterior polars, we had to be careful. Slit lamp examination guided me till I got that IOL Master 700. Now we can see the piece of posterior capsular cataract, posterior capsule. It extends in all these posterior polars. The last two or 3 years, I have not seen a single posterior polar with a break in the posterior capsule pre-op. So I feel the vast majority, we don't have to worry. I
Thank you.
request the other speakers and panelists to share their experience on this. Dr. A.N., can you please tell us how you differentiate the easy ones from the difficult ones? Dr. Srinivas, would you like to comment, please?
Sir, if I can, then slit lamp examination and especially, as you said, slit beam and retro illumination, most of the times PPC is distinguishable from PSC. So most of the times, unless and otherwise the nuclear grade is too high and you are not able to see the exact posterior segment of posterior portion of the lens. Most often slit lamp is leading to distinguish PPC and PSCC. And in case if there is if we find difficulty in distinguishing whether it is dense PSCC or PPC, it's always better to take precautions and consider the case as a PPC case. And as we know, the incidence of PCR with PPC can range from 8 to 36% also, 26% or 36%. But with good care, the incidence of PCR can be reduced. Some of the good surgical tips and approaches. So any doubtful cases, let's just consider that as PPC. And
can I comment, sir?
Please. Sure, we're all waiting for you. Please.
Yes, sir. Sorry, sir. My net had a problem, sir. So this any doubtful cases, I have a simple rule, sir. Doubtful, I know, never discuss and see things. I treat it everything as a PPC and do the surgery. I take a special concern.
I personally feel our PCR rate should be like 1 in 10 or 1 in 20 in PPC. And if you'll all stop doing a lot of hydrodissection and delineation, make a larger rexus, do minimal hydro. If it is a real hard nucleus prolapsed into the anterior chamber and do AC FECO, I think we should not get 30% PCR. That is too high, or even 20%. We should aim at 5 to 10% or less.
The incidence quoted in literature is between 8 and 36, but of course with the advanced instrumentation and refined surgical techniques, they are very less these days. The recent day incidences are very less.
Yes. One way of thinking now, you have a posterior capsule that is weak. Let us accept it is weak. Don't apply any posterior pressure on the posterior capsule. Don't increase the volume in the anterior part of the eye. Anything you want the posterior capsule to be flat. So all your surgical steps, you think of keeping the posterior capsule at the same place. Don't push it down. Don't push it forward also. AC shallow, suddenly it will still break. So all your surgical steps, you try to keep the posterior capsule in the same place, and whatever technique or instruments you use, you work around this. You should be fine. You will slowly get better and better. I expect to get better and better.
Thank you very much. Thank you.
Thank you, sir.
And one question to the panel. In case of progressive zonular weakness, like sir was saying earlier, that you don't prefer to keep CTR, what is your preference to the panelists, whether it is a bag stabilizing device like a CTS or a Sioni ring, or a secondary kind of IOL like iris fixation or a scleral fixation?
Can I ask Dr. Srinivasan Rao to take it up, and then Dr. AN, please?
CTR, I have not commented. Don't have much experience.
Dr. AN, would you like to comment on this?
I don't have much experience.
Yeah. I think we're all escaping. Dr. Lionel Rao
Yes.
and Dr. Kavita, can you please comment on this?
Yeah, regarding the stabilization of the bag, as you said, cases like trauma, CTR definitely works, and theoretically we tell 1 to 3 quadrants up to 270 degrees CTR can help. If one quadrant zonules are very good, also CTR can help in stabilization of the bag theoretically. But in cases of global phacodonosis, like in higher grade of pseudo exfoliation, all those cases, intraoperatively, if we guess that there is going to be a challenge, I will definitely go for a Sianis. So intrascleral fixation using Sianis segment. If that is not possible, then I'll directly go for a scleral fixation of IOL, probably a glued IOL technique. And I had repaired several cases which were done years ago and had come with dislocations. So if 1 or 2 quadrants of zonules are very intact, I'll still go with the only CTR. And if I fear there's going to be a compromise, I will definitely go for a CTS.
Dr. Jayanthan, would you like to comment on this, please?
Yes, sir. So normally what I would prefer is till 3 clock hours of zinc, we can place a 3-piece IOL in the capsular bag with the haptic supporting the capsule. That will do. 3 to 6 clock hours, CTR will do. More than 6 clock hours, CTR will not be a good choice. So always fixation to the sclera is good. What I do in additionally to this, generally one most common progressive zonulopathy is PXF and RP cases. I would like to aspirate the anterior epithelial cells. So because once the rexus starts contracting, it'll pull the bag, and that's when the zonulopathy becomes worse. So if we actually aspirate, when you're doing an irrigation aspiration, aspirate all the 360 degrees of anterior epithelial cells under the rexus, this will give a support for at least a larger time. So that's one extra point I usually do for all the cases.
I do agree with that also. Anterior capsular cells, the migrating anterior capsular cells are the reason for fibrotic contracture of the rexus, and unopposed action from the zonules are the one which decenters the bag. And there are studies also, and there have been publications also, where early YAG lysis of rexus margins also helps in prevention of such things. There are publications on that also, early YAG on the rexus margin.
Very nice,
A larger, larger
comment,
rexus would definitely help. We have to plan for a larger rexus in case of pseudo exfoliation, progressive zonal weakness, and definitely the earliest sign of phimosis, we need to go for radial relaxing YAG incisions.
So this is, I agree with all the comments. So the question was, how do we deal with a progressive problem? So if I have a patient like this, I will look at the patient's age and the comorbidities. Is the patient going to live to be 95 plus, all her relations are very old, or the patient has got multiple heart attack, diabetes, diabetic foot, is going to live only for another 3 to 5 years. So if the life expectancy is less, we can be more aggressive and leave the lens inside the bag. If the life expectancy is expected to be very long, because we are going to have an explosion of drop lenses in the 90 plus population. Because in the Western world, if you see, people live very long. 90 plus is common. They see a lot of drop bags. In India, our generation will live like 90 plus. We are going to see it in the last decade. We're not going to see it between the 70 and 80. So if I have a patient with progressive zonulopathy, and during the surgery, the bag is shaking a bit. I don't have zonular lysis at all. Everything, all the zonules are there, but the bag is shaky and it's a hard cataract. So what I will do is exactly what Dr. Jayanthan said. I will not put it in the bag single piece. I will put a 3-piece in the sulcus and expect the sulcus to support and do only a posterior optic capture. In addition, I will do all the rest. Remove as much cells as possible and don't shift around and shake it too much during the surgery. So this is a progressive problem which is going to hit us when the patient crosses 85 to 90 years of age, not in the middle age. So put the 3-piece lens in the sulcus and do posterior optic capture. That way you are having additional support in the sulcus. If there are any more questions, we will take them. Dr. Seema, would you like to comment? I know you're doing a long-term follow-up of pseudo-exfoliation and drop CTR and bag from your institution. So what are your comments on this?
Yes, sir. His comments are pretty much in line with what the panelists have said so far. The thing is, CTR placement would be in our situation. What we would prefer to do is keep a CTR, like I said, based on the position of the zonular dialysis, based on the progressiveness of the dialysis. If it is more than 6 clock hours or so, then definitely we would consider not doing a CTR. Personally, I haven't done too many bag stabilizations using a CTS or a CONI, but then iris fixation or scleral fixation, depending upon the surgeon's preference, would be the case if it is going to be progressive.
So, Doctor, what are your comments of putting a 3-piece lens in the sulcus and expecting the sulcus to hold it for some more time?
Yes, sir. Yes, that is something which we would definitely do, a 3-piece with a reverse optic capture. And especially in RP cases, even if the cataract on table is not showing much weakness as such, it would be possibly a good idea, apart from washing the lens epithelial cells, it would be possibly a good idea to just put in a CTR preventively to prevent the anterior kind of proximal kind of migration of the bag. The YAG of the margins of the bag would be something which we would have to do at a later date, though.
Thanks, Doctor.
Thank you, sir. Thank you, sir.
If there are no more questions, shall we close the session or?
Kavita ma'am, yeah.
Yes. Thank you very much for this wonderful interactive session, and thank you, Dr. Ramesh Duraidas sir, Dr. Naina sir, and Dr. Srinivas, and also Dr. Jayanthan and Leonel for having stayed for such long time and made this session a very wonderful one. Thank you very much.
Thank you, Doctor. We all learned something, Doctor, from each other. Thank you so much for calling us, Doctor. Thank you.
Thank you.
We also thank Dr. Kavita Lakshmi Madam for moderating the sessions, both the sessions so well, sharing her knowledge and making it more lively. Thank you, Madam. With this, we come to the last session for today's meet. I request Dr. Moses to give the vote of thanks.
Good afternoon, everyone. As we come to the close of this 21st TOS CPD webinar and update on cataract management, it is an honor for me to propose the vote of thanks. On behalf of the President, Secretary, Organizing Committee, and Office Bearers of the Tambaram Ophthalmic Society, I would like to extend a warm thanks to all our guests for the day. It was a wonderful session. All 3 sessions were so lively and so thoughtful. It was a wonderful discussion on various aspects on cataract management. It is an important topic since cataract being the bread and butter for every ophthalmologist. There were many take-home points from managing posterior polar cataracts, using CTR in case of weak zonules and postoperative inflammation, and many more, which we can use in our day-to-day practice. I would like to extend our heartiest gratitude to Dr. Haripriya Arvind ma'am for an excellent video-based talk on the management of extreme spectrum of cataracts.
It was so enlightening, and we have all picked up few techniques on the management of these cataracts. I would also like to thank Professor Dr. Lionel sir for the talk on therapeutic care after cataract surgery. It was a great talk on the various aspects of inflammation post-cataract surgery, its causes, various means to prevent and manage post-operative inflammation. Thank you once again, sir. It was great to have you with us. Thanks to Dr. Lalit Kumar sir and Dr. Jayantan for having a lively debate on rings versus hooks in the management of small pupil. It was indeed a fiery battle between the duo. And thanks to Dr. Kavita Lakshmi ma'am for having a lively discussion in that session. Our sincere thanks to chairperson for today's video-based session, Dr. Ramesh Durirajan sir, co-chair Dr. Armuga Nayana sir, and panelist Dr. Srinivasan G. Rao sir for taking the time out and being with us for the panel discussion and gave their expert opinions on the videos presented. Thank you again. And thanks to Kavita Lakshmi ma'am for moderating the session so lively. Thanks to our presenters for the video session, Dr. Ravi Kumar sir, Dr. Mehul R. Patel, Dr. Seema Ramakrishnan madam for presenting their excellent videos and initiating excellent discussions. Thanks to Dr. Maladi for taking us through the program without any glitch. I thank the scientific committee of Tambaram Ophthalmic Society convened by Dr. Anu Rajugan ma'am for planning the scientific deliberations. And thanks to Dr. Nirmal Frederick sir for always being there to guide Tambaram Ophthalmic Society in the right trajectory. I take the opportunity to thank Novartis and the Nirmal Sai Hospital for supporting today's program. Lastly, I would like to thank every participant of this CPD meeting, without whom this event would not have fulfilled its purpose. And thanks for taking your time on a Sunday afternoon to attend this webinar. Thank you all once again. Until we meet next time, stay safe and have a great Sunday. Thank you all from Tambaram Ophthalmic Society. Thank you once again.
Thank you.
Thanks, Rajamani. Thank you.
Thank you. Thank you, sir.
Thank you. Thank you.
Sir.
Bye,
Thank you,
Dr. Kavita. Bye.
Thank you very much.
Sir. Thank you.
Nice presentation. Thank you.
Thank you.